Let me know, guys. Am I clearly audible and visible to you? Welcome back to all of you on Meduhub YouTube channel. I'm waiting for everyone's reply in the comment box. Good evening. Good evening. I think from my end, everything is perfect. Let me know in the chat box. Is the audio video is perfect? So we'll start the session. Perfect. Chalo. Very good. Thank you. Thank you. Thank you for update. Chalo. Let's start the today's session. And in this today's session, we are going to cover up ophthalmology FMG PYQ based revision, right? So almost everyone has done the previous year questions, but previous year topics which are repeatedly coming in the exams. So what I did today for the all the ophthalmology topics, PYTs, I collected and made a short, crisp and concise MCQs or the crisp and concise the topics in a short form. Okay, so I'm not going to take too much time for the explaining all the topics. We are not covering the full टॉपिक्स ओके पूरा पूरा टॉपिक कवर नहीं करेंगे लेकिन जो स्पेसिफिक फ्रॉम द टॉपिक जहां से क्वेश्चन बन रहा है दैट कंसाइज्ड मैनर आई गिवन टू यू and my request to you before going to exam if you scroll this pdf right I will share this pdf also on the telegram of Meduhub channel also will be available on my channel also right ophthalmology by Dr. Vaibhav Ahuja and you just scroll this pdf before going to this exam right so I hope all the previous year topics and high yield topics I already covered here in a crisp manner. Also, there is a key points also I mentioned. FMG key points I also mentioned on every slide on every topics from the ophthalmology. So that are the very important for you, right? So let's start and this is the revision session. So I'm not going to write too much here. Everything is pre-written on the slide. So we'll discuss about that and I'm going to quickly revise you just my request to you if any doubt just let me know in the chat box right and please revise this all the session please complete this session so that you will be going to cover a full ophthalmology in a quick way okay so this is the table of content which we are going to cover up these are the topics which are most commonly asked as you know very well basic anatomy physiology then lens cataract very important glaucoma cornea conjunctiva lacrimal system dry eye and uveitis sometimes they asking you like 2-3 times they ask the question from the uveitis so I also covered here neuro-ophthalmology always one question coming from here orbit oculoplasty and optics diffraction strabismus retina vitreous and the community ophthalmology right also the image based images I also covered up here and last minute your minute revision facts they also there and some high yield comparison tables are also it's completed in this sections right so starting with the first of all the basic anatomy and physiology of the eye so you guys can see over here about the anatomy you know very well right so as you know very well that eye is divided into the two segments right eye is divided into the two segments what are those two segments the first which is the anterior segment and secondly the second one is the posterior segment right anterior segment and the posterior segment yes doctor notes will be available on the Meduhub telegram channel also available on my channel ophthalmology by Dr. Vaibhav Ahuja and also the you can find out the link of Google Drive in below the video right in the description of video and comment box also okay so you guys can find out all the notes over there right all the sessions from the Meduhub right chalo now covering up fastly with the anterior segment and the posterior segment so how we divided this anterior segment and the posterior segment in the eye so the landmark is the lens please remember so what is the landmark the lens so whatever is the anterior to the lens that is your anterior segment, and whatever is the posterior to the lens, that is called as your posterior segment. So it's quite easy. जो भी anterior lens के आगे की तरफ होगा, सारे structure like iris, cornea, they all are covering into the anterior segment, and behind the lens like retina, that is into the posterior segment. So just remember about it: anterior segment, lens and the structure anterior to it, also the lens is also, and whatever the rest behind the lens, please remember, behind the lens it is your posterior segment. So the landmark is the lens or lens ke aage. Remember this. What are the key features? There is a nodal point. Already we're talking about this nodal point in the refraction also. There is a parallel light rays has been bent on the cornea and the lens. And just about the general structures, आपको सब सारी पता है कि the cornea bends the more than the lens. Please remember the light की जो bending होती है, that in the refraction we are going to talk about it also. That bending of this light, okay, the bending of this light is majorly by your cornea, not by the lens. Lens भी करता है very less. Why? Because of the power difference, right? As you know, the cornea is having the more power. Okay, the cornea is having the more power. So what is the power of the cornea? As already mentioned here, you know very well. I already given in the table here in the cornea power also. So just talk about it, because as the cornea is the more curvature, right? So that's why, and the refractive index is different. So the cornea is having the more bending of the light rather than the lens. And the cornea and the lens, both are the avascular structure. Just you have to remember about it. They both are the avascular structure. There is a no blood supply. There is a no blood supply to the your lens and the cornea. That's why they are transparent. Okay, so as avascularity is the region of the transparency, as the lens and cornea both are the transparent structure, so that's why they are, yes, so they are avascular. Next, aqueous. We talk about the anterior segment. So the aqueous is formed by your ciliary processes. As you know very well, 70 to 50, 7 to 75 are the ciliary processes in the per eye, right? We have, and these are the ciliary processes are going to make your formation of the aqueous humor. As you know very well, the ciliary body, where is the aqueous humor? The ciliary process are where? It is in the ciliary body, and ciliary body have the two parts plicata and parts plana, right? So it is from the parts plicata part, which is the processes of the ciliary process. And you know, aqueous drainage through the angle, which is known as the peripheral space between the iris and the cornea. So you can see here, I already put in a diagram over here. This is the your aqueous draining process, right? How the aqueous will be going to drain out, right? So in this condition, you can see over there that the aqueous humor is coming, producing from the your ciliary body, you can see. And after the production of from the ciliary body, it is coming in front of, yes, it is coming in front of the lens. Yes, it is coming in front of the lens, which is the your posterior, what we can say, which is the posterior segment or the chamber, please remember. Okay, so this is coming to the posterior chamber, and it is coming through the iris. This is the your behind the iris, this is the your pupil. So from the posterior chamber, it has come to the anterior chamber through the your pupil, and it is coming to the angle. What is the angle here? Please remember, at this is the iris and this is the cornea, so this is known as corneo-iridal junction, or you can say the iris and corneal junction, right? So here is the your Shim's canal, right? Canals of Shim's, and from here your aqueous humor will be getting drain out. So this is the drainage for the aqueous. Now, what is the key measurements which you have to know, remember about it, which is very, very important table which I given over here. Normal IOP is your 10 to 21 mm Hg. Please remember about it. Normal intraocular pressure is the 10 to 21 mm Hg. What is the orbital capacity? This orbit which we have, right? What is the capacity of it? The orbital capacity is the 30 cc. Please remember, orbital capacity is the 30 cc. But nowadays they can ask you what is the eye, right? Eyeball capacity is the your 6 cc. Okay, please remember, eyeball capacity is the your 6 cc, right? Next, what is the orbit shape? Please remember, the shape of the orbit is the your quadrilateral pyramidal, right? So as it is a pyramid, ना, आप लोगों ने देखा होगा, when you saw in the anatomy, you saw the skull, so you saw the orbit cavity, right? So this is the orbit cavity shape, is your quadrilateral pyramidal shape. Next, the axial length of the eye is the your 24 mm. 24 mm. And what is the your anterior chamber depth? Please remember, what is the depth of the anterior chamber? That is your 2.4 to 2.5 mm, right? And how we measure this axial length, right? Axial length का मतलब होता है anterior to the posterior length, AP. AP length we also can say this. So this axial length is measured by the ultrasound probe, which is known as A scan, which is known as A scan, right? So we say this the A scan. हम इसको क्या बोलेंगे? A scan बोलेंगे. Now, for the refractive powers, you have to remember the values of such refractive power. Total eye refractive power is your 58 to 60 diopter, right? What is the cornea? What the consisting of the cornea? Like total eye power तो दो lens और cornea दोनों का मिलाकर होगा. So what is the consist of the cornea? 43 to 45 diopter, right? And the 16 to 17 diopter from the lens, right? So the totaling of it is the 58 to 60 diopter is the total eye power. Please remember the corneal index, refractive index of the cornea is the 1.37, right? 1.37, and the lens is having the 1.39. Please remember, it is maximum at the center, right? It is remain at the maximum in the center, right? So FMG key point, as from the anatomy, FMG key point is saying what? It is related to your, first of all, from the eye, total eye power, right? How much the cornea and how much from the lens. And please remember, the cornea and the lens are the avascular for the transparency. As they are avascular, that's why only they are the transparent, right? Just think about it. If the blood vessels are present on the cornea or the lens, right? So blood vessel वहां से pass होती. So blood is having the red color because of your hemoglobin, right? As you know very well. And the cell structure will be going to passing through here. Vessels pass hoti, so that could be not maintain the transparency of the lens in the cornea. So that's why remember about it. They are the transparent structure. They are the transparent structure. Is it clear? So this is the about the anatomy previous year topics and the highlighted topics we covered over here related to the anatomy of the eye, right? So now we are moving forward for the next topic, which is very, very important, lens and the cataract. Every year in the FMG, we are going to see here 1 to 2 questions from the lens and the cataract, right? First of all, I'm starting with the lens structure, physiology, and the accommodation, right? What is the meaning of this, all of this, right? So first of all, listen about it, that your this lens structure are the single layer of an anterior epithelial cell. So the only and only is the single layer. Anteriorly we have the epithelial cell. The posterior side we don't have any epithelium. Please remember about it. The posteriorly we don't have epithelium. So you can see over here. You can see over here. This is the lens epithelium in the diagram. Just in the anterior side. The posterior side you can see. This is the posterior side. The posterior side there is a no epithelium. Okay, no epithelium. Clear? Please remember there is a no epithelium in the posterior side. Now, the equator of the cells are from the lens fiber. Please remember about it, and they're covered with a very elastic capsule. So now you can see this. All of the structures are covered by one important structure which is known as your lens capsule. So the outermost we have the lens capsule, right? A capsule bag hai, a capsular structure hai, which is covering all of the, which is having the all of the structure inside it. Okay, which having the all over the structure inside it. And please remember about it. This is derived from the your surface ectoderm. The lens is derived from the surface ectoderm, and this is the thinnest part at the capsule at the posterior pole. Okay, the thinnest part is the capsule and the posterior pole, because posterior pole is, you can see, this is the very thin. There is a no epithelium, so that's why it is having very thin capsule on the posterior side. The lens is formed throughout the life. Please remember the lens fiber are forming the throughout the life. And please remember, what are the youngest fiber? The cortex is the youngest fiber, right? The cortex is the youngest fiber. So you can see over here, these the outer structure you can see over there. This is the white color structure, that is your cortex, right? That is the cortex. And this middle one is the your nucleus, right? And in this nucleus you can see there's a different fibers over there, like your embryonic nucleus, this size. Then we have the your fetal nucleus increasing the size, and you can see this, the outermost one is the your biggest one is the your adult, or we can say the mature nucleus. Okay, adult nucleus is there, right? Also, so in the central part we have the nucleus, and then periphery is covered by the cortex, and this all the structures are covered by the your capsular structure, which is known as lens capsule, which is known as lens capsule. And on the anterior side, we have the anterior epithelium. The posterior side, there is a no epithelium is present. Is it clear? So posteriorly, there is a no epithelium. Please remember, posteriorly, no epithelium. Now, what is the lens physiology is saying? Like dehydrated structure, as we know, it is a dehydrated structure. So this hydration causes the cataract, right? The main thing is here, as it is a dehydrated structure, we are having, if the hydration of this is happening, that is causes the cataract. One of the most common cause of cataract. Also, please remember, as we talked about it, it is an avascular structure. So now your doubt is there, sir, if the avascular structure, how they are getting this nourishment, okay, and the nutrition from it. So please remember, the nutrition and the nourishment is coming from your aqueous humor. So as the aqueous humor is the flowing from the making from the ciliary body, it is flow from the anterior side. So this anterior epithelium is getting the nourishment to this lens, right? Now the primary metabolism is the anaerobic, 80% by the glucose, as you know very well. We'll talk about in the diabetic cataract, right? So you know about it. So this is all from the 80% is the your anaerobic, right? This is the primary metabolism, which is the anaerobic. So 80% is through the glucose is happening. Now, if we're talking about the accommodation, right? So in the lens, we studied about the structure, which is the anatomy of a lens. Then we studied about the lens physiology. Now we are moving forward for the important topic of the lens, which is your accommodation, right? What is the mean of accommodation? Please remember about it. Whenever you are looking on a far objects and suddenly you see on the near objects, so in this condition our eye is doing some our eye is doing the some changes, right? Our eye is doing the some changes over it, and for this is called for the making it, this is called as increasing the power of the eye, and this is called as your accommodation. Now there is the steps of accommodation is there. Please remember about it. What is happening in the accommodation? There is a ciliary muscle. The three structure are here. You can see in this diagram I already mentioned. This is the your ciliary muscle, or we can say the ciliary body. Okay, this is the ciliary muscle or the ciliary body. The next structure you can see, these are the thin thread-like structure are the your zonules. These are the your zonules. Okay, so this is the ciliary body, or we can say the ciliary muscles. Then these are the zonules, and the last structure which you know very well, which is the your which is the your lens, which is your lens. Is it clear? Perfect. Now, listen this part. As the ciliary body and this zonules are the opposite of it. Why? If the ciliary body will doing the contraction, the zonules will do the relaxation, right? If the ciliary body do the relaxation, the zonules will do the contraction. ठीक है? ये दोनों एक दूसरे के opposite है. So what is happening in the accommodation? Please remember about it. Please remember about it. As the ciliary muscles, you can see in the second step, this is the accommodative step, right? We can say the accommodation state. Okay, and what is this? This is the unaccommodation state. What we are finding in this, first of all, as we talked about in here, in the unaccommodation state, you can see the ciliary muscle will do the what? In this condition, the ciliary muscle will do the relaxation. As I told you, if ciliary muscle will do the relaxation, what will be done by the zonules? As you know very well, it is just opposite of it. So ciliary zonules will do the contraction. As you see, the ciliary muscle will do the contraction. So these are the thread-like structure. They will pull the lens. As they will pull the lens, so this curvature, you can see this curvature of the lens will be getting flat. Okay, as this lens will be getting flat, so you know very well, this is for better for what? The flat lens is for the better for the far vision, or we can say the far vision, or we can say the distance vision, right? So you can see these are the three steps which is mentioned over there, right? Which are clearly mentioned over there, that is clearly mentioned over there that the ciliary muscle is relaxed and the zonules are the your taut, which is the, we can say the contracted, the zonules, and the lens is getting flat, right? And the lens is getting flat for the what? It is getting flat for the descent vision, for the descent vision. Now we are talking about the accommodative state. The second image which you can see here, this one is the for the accommodative state. Okay, this one. And in this accommodative state, what will be happen? You can see over there, this is the ciliary muscle. The ciliary muscle will do the contraction. As you know very well, ciliary muscle will do the contraction. So what will be done by the your fibers? Yes, what will be done by the your zonules, right? Zonules, we can say fiber, not the zonules. So the zonules will do the relaxation. As you can see, the zonules will be getting relaxed. So what will be happen with the lens? The lens will be increase the curvature, right? Then increase the curvature, and as they increase the curvature, it will increase the eye power. Okay, increase the eye power. Okay, so this is for the what? This is for the near vision. Yes, so this is for the near vision. For far vision, unaccommodative state. For the near vision, we need the accommodative state. For near vision, we need the accommodative state. Is that clear, guys? Is it clear, guys? Sir, one question regarding the thalassemia triad. I know it's of the can thalassemia triad can be given the thalassemia triad for the pregnant woman. Thalassemia triad for this we can do. Yes, we can do. No issues. Yes, we can given. Is it clear, guys? Perfect. Chalo. Now, so these are the steps for the accommodation. The ciliary muscle will be good doing the contraction. The jonules will be relaxed and the lens will be getting round, or we can say it is for the near vision, increasing the curvature. Now, just remember about the FMG key point as I mentioned in every slide, which is very, very important. The lens I derived from the surface ectoderm. You have to remember. And what are the youngest fiber in the lens, which is the cortex. Please remember the cortex is the youngest fiber. Cortex is the youngest fiber. Now, moving forward for the next, which is the lens disease, and very important disease of the lens, which is your cataract, which is your cataract. Now, we have the classification and the types of the cataract also. So, in the quick manner, we are going to revise it, right? In the quickly, we are going to revise it. So, you know very well the definition of it, the any opacity of that hides the optical homogeneity of the lens, right? So light cannot pass through the lens. Like opacity will be there, right? Uh, that will be there causes the cataract, right? We can say the clouding of the lens. है ना? Short form में इसको clouding भी बोल सकते हैं, right? And the type of the many types of the cataract as the based on the your anatomical base, right? We are talking about the anatomical base, like in the cortical cataract, which is the cuneiform, right? In the cuneiform, which is the having the cortex part is covered. Then we have the nuclear cataract, which is having the central opacity, which is having the nucleus will be getting the opacities. The posterior subcapsular, which is on the posterior side where we don't have any epithelium, that will be getting the opacity, which is known as posterior capsular subcapsular posterior subcapsular cataract, right? PCA. And the later on we have the next we have the diabetic, right? Which is a snowflake cataract, which is seen in the patient of diabetes patients, like metabolic diseases patients. And also we have the complicated cataract, and the last we have the traumatic cataract. So we have these type of the cataracts. Also, now we have the acquired type of the cataracts. Also, we have to talk about it. So let's talk about the cortical. What will be seen in the cortical or the cuneiform. In this condition, we are going to find, right? What we are going to find in this condition, please remember, the first of all, you will be going to find there the spoke-like opacities. And these are the most common senile type of the cataract. Okay. So, अगर हम बात करें lens की, so lens का periphery, please remember, as this is the lens and this is the nucleus of the lens. So, this rest is the, this rest one is the your uh, cortex. So in this cortex, we are going to find this kind of spikes will be going to see. Okay. And this spikes is known as your cuneiform, or we can say the cortical cataract, right? This is the most common type. The next we have the nuclear cataract. Please remember, at in the nuclear cataract, we will be going to find the central opacities, right? What will be going to find the, we're going to find the central opacity. So this one area, the central part of this will be getting, yes, the central one will be getting what? Opacities. So that will be known as your, that will be known as your nuclear cataract. And please remember, in this patient, what will be going to find? The day blindness, right? Day blindness. And what do you mean by the day blindness? Please remember about it. If I'm drawing a lens over here and opacities are in the central part, okay, just I'm drawing over here. And now think about it, and this is the iris, right? So this in the daylight, what will be happen? The pupil will be do the contraction, and this middle part of the light, okay, what will be going to pass here? The central part of this light will be going to go throughout this. And what will be happen as the central light, okay, the periphery will be not going to cross it, because as the pupil is getting constricted, as the pupil is getting constricted, you can see over here, right? So ये तो जाएगा नहीं. The central will be getting opposite. Central will be going to the central ray will be go, and they will be getting stuck over here in the opacities of the nucleus. And in the daytime, the patient is having the blindness over there. What will be happen in the night time? Just think about it. It is a very easy thing that their pupil will be getting dilated. So जैसे pupil dilate होगा, so क्या होगा? These light will be also getting crossed. Okay, ये light भी क्या हो जाएगा? Cross हो जाएगा. ठीक है? This the iris है ना? Iris dilate हो गया, pupil dilate हो गई, iris dilate हो गया. and this light will be going to reach. So the patient is having not the blindness. Patient को, yes, of course the blurring vision will be there. ऐसा नहीं clear होगा. The blurring vision will be of course there, but the patient, the thing is here, but the patient is not the blind. This is the main thing. Okay, so patient blind to नहीं होगा. So the patient is having in this condition the we can say the day blindness. The next we have the posterior subcapsular cataract. This is the max vision loss will be going to seen over there, and this is most commonly by the drug abuse like steroids, chloroquines, and the busulfan. Right, these are the disease. These are the your drugs which are can cause the your, we can say the we can say this is by the drug induced cataracts, right? Also the next one, which is the diabetic cataract, you can know about it. This is most commonly seen with the diabetes type 1, right? Type 1, and this is due to the sorbitol accumulation, right? So the sorbitol will be getting accumulated inside the lens, and because of that, as you know, this the having the uh, anaerobic use of the glucose, 80% from the glucose, anaerobic metabolism will be there. So that's why the sorbitol will be getting accumulated inside the lens, and this is the are causing the diabetic cataract. In the complicated cataract, we talk about it, the polychromatic lusters will be going to see, which is known as your bird cam appearance. Is the most commonly seen in this complicated cataracts. Also, the traumatic cataract, this is the rosette shaped cataract, which is having the star in the posterior cortex. Like there will the star will be seen, and we can say this is the rosette, right? As the flower of the rose is having the petals over there, so this is known as the rosette cataract. Also, we have the acquired cataract type. Please remember, in the acquired type of the cataract, what we are having, in the acquired we are having the senile, which is the most common. Please remember, the most common type of the cataract is the senile cataract. Okay, so this is the physiologically we can say like after the age of 45, right? Out after the age of 45 years, the patient is having what? The clouding of the lens. The patient is having what? The patient is having the clouding of the lens, and this is the your senile cataract. Okay, because of the age, है ना? Age की वजह से हो रहा है. चलो, next we have the metabolic cataract. The metabolic cataract, as we talked about the diabetes mellitus, right? अभी अभी हमने बात किया snowflake cataract. Also, we're going to see the galactosemia, Wilson disease, right? In this conditions, the metabolic disease conditions also we are going to find the patient is having the cataract. The third one, which we have the complicated cataract in the cases of uveitis or the your retinal detachment or the glaucoma, they can cause the complex, like they can do the complicated, right? We can say the secondary type. Yes, we can say the secondary type of the cataract. Okay, so this is the complete your complicated cataract. Also, we have the toxic cataract. Yes, what is the mean of toxic cataract? Because of the some drug abuse, right? Like the steroids, as I already told you, chloroquines, and the your mitotic drugs are also over there. So these are going to cause the your, they will be going to cause the your toxic cataract, right? The third one, the fifth one, we have the traumatic cataract. In the traumatic cataract, we have the blunt, penetrating, or the electrical. So the three type of the traumas we are going to find over there. The first one, which is the blunt injury, like fist injury, or the, we can say the cricket ball injury, tennis ball injury, that causes the blunt injury. The second one is the penetrating. Maybe the pen or maybe the knife or maybe anything can be penetrate the this cornea, right? This is called as the penetrating trauma, right? And the last one, electric, the electric shock, right? The last one we are talking about the electric, that is the related to the your electric shock, right? So this is the electric trauma. Clear? So these are the three type of the your traumatic cataract. Also, the radiational by the UV, infrared, or the X-rays, they are also going to cause the radiational X-rays, the radiational cataract, and also this is having the systemic diseases, which is called as the presenile cataract. We're saying it is the presenile because before the age the patient is having the cataract, right? So these are the your acquired type of the cataracts. Please remember, there is a, we are having the different stages of the senile cataract also, right? As you know very well, in the senile cataract, the most commonly we have the cortical, right? Cortical one, the most common. Also, the second one is the nuclear, second most common. The third one will we have the posterior subcapsular, and the fourth one we have the mature cataract. Okay, fourth one is the mature cataract, and fifth one we have the hyper mature cataract, which is known as your Morgangian cataract, right? Which is known as your Morgangian cataract, right? This is the stages, we can say the steps of the your senile cataract, right? If the cortex is involved, that is known as your cortical cataract. If the nucleus is involved, that is known as your nuclear cataract. If the only the posterior subcapsular part is involved, that is known as the posterior subcapsular. But what will be happen in the mature cataract then? Please remember, the whole entire lens will be getting opaque. Understood? So in the mature cataract, what will be happen? Entire. Please remember, the entire lens will be getting opacities, right? And what will be happen then in the hypermature, right? This is the question, right? Then what will be happen in the hypermature? So in the hypermature cataract, what will be going to happen? In the Morgington cataract, the lens fiber, the cortex, and in the lens fiber, the cortex and the nucleus is there. So this nucleus will be getting shrunken down, and this cortex will be getting the liquefaction, right? This total cortex will be getting liquefied, and this is called as your Morgington cataract. And this is the most common complication of this Morgington cataract is your phacolytic. Please remember about it, the phacolytic glaucoma. Right? What will be the phacolytic glaucoma? As I told you, the liquefaction of the cortex will be happen, right? As the liquefaction of the cortex will be happen, this lens protein will be leaking out, and this will be going to block your trabecular meshwork. As they will going to block the trabecular meshwork, there will be the accumulation of the aqueous humor, and they will be going to increase your intraocular pressure. They will be going to increase your intraocular pressure. Is it clear, guys? Chalo. Very good. Moving forward, coming to the key points again, FMG key points as already mentioned in the every slide. So the posterior subcapsular cataract cause the maximum diminution of the vision. Please remember about it. And if we talk about the common cause, right? If we talk about the common cause of are the steroid and the chloroquine, right? The steroid and the chloroquine are the most common cause for the common, we can say the toxic, like in the toxic cataract, we can say yes, steroid are the having the more role play. Okay, steroid having the more role play. And we talked about it, the phacolytic. Yes, phacolytic glaucoma is the most common complication of hypermature, which is the Morgington cataract. Hypermature is the your Morgington cataract. Is that clear? Is it clear to you guys? Right? Let's move forward. Let's move forward for the next one. The next slide is saying the hypermature cataract, as we talked about it, which is your Morgington cataract, right? We already mentioned over this hypermature cataract. In the mature, yes, in the mature it's okay. Pura entire lens will be getting opaque, but in the hypermature is happening what? This will be the liquefaction of the cortex, right? So the most common complication is your phacolytic glaucoma, as we talked about it. And in this condition, the lens proteins will be getting leaks through the your wrinkled capsules, and this protein will be going to block the trabecular meshwork. Yes, this is for the aqueous drainage, है ना? Aqueous drainage क्या हो जाएगा? Block. Drainage will be getting block. Okay, so the aqueous drainage will be getting block, right? And as you know, we see the capsule will be showing the wrinkles over there. And as we give it the traphan blue dye is used, the capsule is not getting too visible because this entire protein will be getting the entire proteins will be getting leaking out from there, and the capsule is getting the wrinkles, right? The most common complication of this hypermature Morgington cataract is the subluxation in the case of trauma. Okay, so most common complication of this subluxation is the trauma, right? If the any blunt trauma is there inside the eye, so the lens can be getting subluxation. What is the mean of subluxation? The lens is go to the posterior segment. Okay, so lens कहाँ चला जाएगा? Lens will be go to the posterior segment. Is that clear? So this is the your hypermature Morgington cataract. If we talk about the diabetic cataract, right? It is a diabetic cataract, as you know very well. It is known as the snowflake cataract, also the snowstorm appearance, right? So what will be seen inside the eye? There is a snowflakes will be going to seen in the on the lens, and this is the most commonly seen in the type 1 diabetes mellitus. As you know very well, type 1 and type 2. So this will be seen in the type 1. Or what is the cause of it? Please remember, this is the sorbitol accumulation inside the lens. Okay, so the sorbitol accumulation will be seen over there, and the enzyme which is responsible for your which is your aldose reductase, right? Which is your NADPH dependent, which is your aldose reductase, right? And the frequently the patient is having what? Frequent glass changes. The patient should have the diabetes mellitus. Please remember about it. If they mention the diabetes mellitus patient and having the frequently glass changes, we can think about the diabetic cataract. But if they don't mention the diabetic patient and mention over there the frequent changes in the glasses, so keratoconus can be the cause of it. Please think about it. Also, if they mention opacities on the lens, right? So we can go for the diabetic cataract and with the frequent changing glasses. If they don't mention any opacities on the cornea or on the lens, so we should go for the keratoconus. Please remember about it. And these are the reversible if treated early. If in the early stages we are treating the diabetes, sir, what we have to for the reversible, what we have to treat? Yes, we have to treat the diabetes mellitus. Yes, now your question to you, how to treat the diabetes mellitus? We need the glucose control. Yes, control level of if the glucose is there, so there will be the no more accumulation inside the your lens. Is that clear? Now, what is the fluctuating refraction errors will be seen in the diabetes mellitus? Like at the it's called, the condition will be called as the refractive shift. Please remember about it. If the patient is go to the hyperglycemia, that is causing the myopic shift. Why? Because it will be swelling will be going to increase the curvature. The lens, as there is accumulation of the sorbitol. So sorbitol जब lens के अंदर accumulated होगा, so they will be increase the curvature. Curvature increase होगा. If the lens is swelling, swelling से curvature increase होगा, तो eye का power increase होगा. That will be the myopic shift. If the patient is having the hypoglycemia, what will be happening? That will be cause the hypermetropic shift, because towards the lens curvature will be getting decreased, shrink हो जाएगा, accumulation होगा ही नहीं अब hypoglycemia में. So the patient is having what? The patient is having the yes, your hypermetropic shift. So these are the shift which is called as a myopic shift and your hypermetropic shift. Is that clear? Which is called as a refractive shift. Now, please remember the FMG key point. As always, I already mentioned in every topic slide. Please remember the phacolytic glaucoma is the most common complication of the hypermature cataract, which is known as your, yes, Morgagnan cataract, right? And what is the reason of it? Yes, the lens protein blocks the trabecular meshwork. The diabetic cataract, yes, the sorbitol accumulation. And please remember by the which enzyme? Yes, your aldose reductase. The enzyme is the responsible for it is your aldose reductase. Aldose reductase. Is it clear? Very good. Very good. If any doubt, guys, you can directly ask me in the chat box. Okay, the live chat is going on. Please, if any doubt, you can mention over there. We'll talk about it related to this. Clear? Chalo. Now, moving forward for the next, moving forward for the next, is the your special cataracts are also there, right? And in this special cataracts, we have the first one, which is the Glaucoma, which is seen in the your Wilson diseases. Also, we have the Lowen syndrome and the complicated cataracts. We should have to talk about it, and the traumatic cataract. So these are the some special cataracts are also over there, which we have to talk about it. So first of all, we are starting with the your Wilson disease cataract. There will be the golden brown copper. Please remember, there is a golden brown copper deposition in the Dasman's membrane, which is known as KF ring. Please remember this question, right? So they asked you in the previous year question, what is the KF ring? So, and where it will be going to seen, it will seen in the in the Wilson disease, right? In the Wilson disease. And please remember, it start at the superiorly and inferiorly and then become the circle. Okay, so it start with the superiorly, half of it, and then inferiorly, and then it will be become the entire circle. That's why it is known as the KF ring. All the neurological Wilson patient have the KF ring. Please remember, as the patient is having the neurological symptom of the Wilson, so the patient is having the KF ring. That is a thing, confirmed thing, right? The only 65 to 67% is the your hepatic involvement is having the KF ring. In the hepatic, they have the very less hepatic, because the your copper should reach to the your Desmond membrane, right? So that is the main thing. And please remember, in this special feature we'll be going to see, which is known as your sunflower cataract. Okay, we are saying it is the sunflower cataract. So it's look like the your sunflower cataract, which is known as your sunflower cataract. Also, we have the Lowen syndrome. In the Lowen syndrome, what we have the oculocerebral and renal syndrome, right? Which is also known as oculocerebro-renal syndrome, right? So all these three will be having the together over there. The feature is having the posterior lenticulus, which is having the oil globule reflex on the slit lamp. That's, you can see what is the main important thing. This is giving you the oil globule reflex on the slit lamp. It's look like, and the oil globules are over there, and the anterior lenticulus will be seen in the Alport syndrome. Please remember, posterior lenticulus will be seen, lenticulus will be seen in the Lowen syndrome. The anterior will be seen in the Alport syndrome. And please remember, the Lowen syndrome, the most commonly seen in the males. This will be most commonly seen in the males. Also, the what about the complicated cataract? If we're talking about the complicated cataract, in the complicated cataract, we are going to find the first one. This is due to the anterior or the posterior segment diseases. The first of all, So the complication कहाँ से आएगा? जो intraocular diseases होंगे, from that only. So the most commonly we are seeing the posterior subcapsular cataract, which is the most common complicated cataract. What is the pathognomic? This is having the polychromatic luster. We are going to see the polychromatic lusters will be seen on the lens, and the appearance of it is the Brad cum appearance will be going to seen, and this is also your MCQ, right? And the last, as we already talked about it, that your traumatic cataract will be having the rosette shape cataract, and rosette shape will be seen in the due to the blunt trauma. Please remember about it, the fist injury, or we can see in the cricket ball injury. In such conditions, we are going to see the rosette shape cataract. And please remember, this is start from your posterior cortex. It will be going to start from your posterior cortex, right? It means it will be going to start from the posteriorly side. Okay, ये कहाँ से start होगा? It will start from your posterior side. Is it clear? चलो, let's move forward. Just a minute. Now, moving forward for the next. Moving forward for the next, which is your voice ring, right? Voice ring. What this is the anterior capsule, which is seen also in the blunt trauma, right? This start from the posterior cortex, and the voice ring will be going to seen in the blunt trauma category. It will be going to seen in the blunt trauma category. Now, what are the important FMG key points related to this complicated cataracts, right? So, what are the things? Please remember the first of all is your KF ring. Please remember KF thing. Ring starts superiorly, inferiorly, and then it will be joining over there and seen in the Wilson disease. Sunflower cataract will be seen in the Wilson disease, anterior lenticulus, Alport syndrome, posterior in the Lowen syndrome. These are the important key features which is related to your special cataracts. Now, moving forward for this was all about the senile cataract, or we can say the acquired cataract. But what about your important about your congenital cataracts and the special, which is your rubella syndrome? Please remember about it. We have to talk about the congenital rubella syndrome, right? I hope you studied this in the your pediatric, right? I hope you studied this in the your pediatric. We just revise over here again, no issues, right? So we are starting with the first of all. Yes, we are starting with the first of all your congenital cataracts, right? So we are starting with your congenital cataract. So in the congenital cataract, we have the blue dot cataract, and please remember this is the most common congenital cataract, which is the feature by the Down syndrome, right? So if the patient is having the Down syndrome, the congenitally the patient is having what? The patient is having the congenitally cataract will be there, and this will be known as your blue dot cataract. Also, the patient is having the lamellar cataract. This is the most commonly causing by the marked up with the loss of vision, and this is the mostly associated with your vitamin D deficiency. Please remember about it. Yes, the vitamin D deficiency can cause the cataract. Yes, and also we have the riders, which is the additional opacities are the features. Okay, and please remember also it can this your laminar cataract also can be caused by the rubella. Yes, in the rubella syndrome we are going to find the cataract will be there, and posterior polar cataract, the posterior polar cataract will be your onion peel appearance will be going to seen, and this is the high risk of the posterior capsular tearing during the surgery. So as uh, the lens is very small, or also the capsule is not so much mature, and while doing the surgery we have to clean your posterior pole, right? And it can be the trauma, we can say the like during the surgery it is easily it can be getting ruptured the posterior wall of your capsule, right? Also, we have the oil drop cataract, and this is the seen in the galactosemia. Just remember about it. It is a reversible cataract. If we treat the galactosemia, this cataract will be getting resolved. Okay, so that's why it is going the reversible. Rest all the cataracts are the irreversible. Please remember about it. Only the oil drop cataract is the your reversible cataract. What about the your congenital rubella syndrome? It is having the triad, right? It is having the triad. What is the triad? Cataract, heart defect, and the deafness, right? So the congenital rubella syndrome is having the what the three triad. What are the three symptoms over there? Yes, cataract. Please remember the nuclear in the your nuclear pearly, which is the most common type of the cataract will be seen over there. Heart defect and the deafness will be there. Also, if we're talking about the ocular findings, right? What will be the finding of the ocular features will be seen in the congenital rubella syndrome. So we are going to find over there the patient is having the salt and paper fundus, which is the most common ocular feature. And what is the mean of fundus? Yes, we have to see the retina. Okay, retina. So the retina will be looking when we see the all the fundus of it. So the fundus of the retina will be going to seen in the salt and pepper appearance. Also, it is having the micro ophthalmos. The axial length of the eye will be getting less than 21 mm, right? So that's why it's called the micro. And the rubella keratitis can be seen, right? And angle anomalies, and if the angle anomalies is there, that can be cause the glaucoma also. So these are the related to their other ocular features in the congenital rubella syndrome. The other congenital cataract, like shield cataract, is there, which is features are the atopic dermatitis, and this associated with the your. We are saying it's the pre-senile cataract. It will be seen in the pre-senile age. And the key point of the FMGE key point are here the rubella triad. Please remember what is in the triad: cataract, heart defect, deafness. Okay, and remember about it the salt and pepper fundus, which is the most common ocular feature of the your congenital rubella syndrome. It will be seen in the congenital rubella syndrome, right? So this is the congenital cataracts, or we can say the rubella syndrome cataract, right? Now, moving forward for the next, we have the cataract surgery. So I compiled a very in a single table all the types of the your cataract surgeries, which is very well: ICC, capsular cataract surgery, small incision SICS, and your phaco. So every the key features of the every particular surgeries and the incisions we have to talk about it. So please remember the large incision is given into the your intracapsular cataract surgery. The extracapsular cataract surgery, we have the 10 to 12 mm of the cut, and the next we have the SICS, which is the small incision. ठीक है, तो extra capsular से तो छोटा ही होगा ना. Yes, so this is the you are having the 5 to 5.5 mm of it, and the least सबसे कम किसमें होगा, that will be in the phaco, just 2.75 to 3.2 mm, right? Which is the, we can say this phaco, we are saying the sutureless surgery, right? Also the SICS is also the sutureless, right? Please remember, in the SICS also we are not giving the suture. Yes, in the ECC we are giving the sutures. वहां हमें sutures यूज करना पड़ेगा, ठीक है? So in this too we have to use the sutures, ठीक है? वहां तो large incisions है, suture तो चाहिए ही चाहिए, right? The small incision 5 mm का incision है, we don't need any suture over there. In the SICS and phaco are the both are the sutureless surgery. Please remember, phaco में भी suture use नहीं होगा. In the SICS also we are not going to use the suture. We are not going to use the suture. Is it clear, guys? Chalo. Now, what are the key features of these, right? Key features, yes, of course. Nowadays also we are have to do in the complicated in the complication we have to do the your ECC, right? Intracapsular. So now listen this part. In the key feature, what is this? In this condition, we whole lens capsule will be getting removed, which is known as your cryo extrusion, which is the best for it. ठीक है? तो इसमें हम क्या करेंगे? Please remember about it. We remove the total lens. पूरा lens ही remove कर देंगे. कैप्सूल भी, फाइबर्स भी, एवरीथिंग इज रिमूव. जॉन्यूल्स के साथ ही टीयर करके हम उसको आगे रिमूव कर देंगे. इन दिस कंडीशन व्हाट वी हैव टू डू देन, वी हैव टू डू द AICOL, right? What we have to do? We have to do in this condition, we have to do the AICOL. What is the mean of AICOL? We have to do the anterior intraocular lens implantation. Okay, so we have to do the in the anterior chamber. Okay, ACIOL. Just a minute. We have to do the ACIOL. In this condition, we'll do the ACIOL. Anterior chamber intraocular lens implantation. So, hum will put this lens into the your anterior chamber. Okay, because the jonules पूरा capsule remove कर दिया है हमने, so the lens will be not getting over there. Okay, so only we are doing nowadays for the only for the subluxation of the lens. If the jonules is tear already, so we have to do this, and this is the more than 9 hours of this subluxation is the having the ICCIS, and also we have this is the contraindicated in the children. We are not doing in the children's. We are not doing this ICCE. Is it clear? Now in the ECC, extracapsular cataract surgery, what will be there? There is a non-foldable IOL we have to use and this is a made up of the your PAMA. And the foldable is the made up of the acrylic and the silicone, as you know very well. And this is the hydrophobic acrylic is the best for the your posterior chamber intraocular lens should be PCO, right? Next, if we are talking about the SICS, please remember the features of the SICS is the best because there is a no sutures, and please remember there is a negligible astigmatism is there. But what is the main? The manual small incision should be given in this condition. The next, the best one, if I am talking about abhi ke liye best kaun hai? The best is the your phaco. Nowadays, we are doing more over the phaco surgeries. And in this condition, what is the key feature of this phaco? Please remember about it. In this condition, we need the phaco emulsification probe and the machine. Is it clear? So what we need in this condition, we need the phacoemulsification probe and the machine, and the frequency of it the 40 to 50 hertz for the emulsions and the aspiration. So this machine will do what? It will break down all the nucleus and the fibers. The capsule will be remain over there. And in this condition, we are using the foldable lens in this condition. And please remember, this is the gold standard, and foldable lens, foldable IOL should be put it in this side. So please remember, as it is the gold standard, so this is the best for the surgeries. Okay, we are doing most over nowadays. We are doing this. Clear? Now, for the doing this surgeries, how we are going to calculate the like your intraocular lens power. So there is a formula. They are not asked even in this FMG exam, but in the INA set they are asked this formula. So just remember the SRK formula. What is the SRK formula? P is the power here. A is the constant, minus 2.5 L. L is the axial length, and minus 0.9 K. And what is the K? It is the your keratometry readings. So हमें क्या करना होगा? We have to do the axial length. For the axial length, we have to do the A scan. Simply we as we done, right. After the done with the A scan, we'll put this axial length into this formula. Also, we have to do the keratometry of the patient, and we get the keratometry numbers from there, and we put instead of the K, right? A is the constant here, and after the doing this all of it, we are going to find the power of the lens, right? Power of the intraocular lens, which we are going to put in this patient. Clear? Now, time of the surgery, if we are talking about it, if the patient is having the congenital cataract, operate after 1 month. Yes, after the 1 month, we can do the OT of this patient. Avoid the to avoid the amblyopia, as soon as we have to do the, as it is the feasible, we have to do. ठीक है, जब perfect time लगे patient के लिए for this child, we have to do, because if we wait for it for long time, the child will be getting the amblyopia, right, which is the lazy eye. What is the now the key feature of the FMG, which is the key point? Please remember, the phaco is the gold standard. Why it is the gold standard? As you know, the incision is the very less. Okay, this is also the sutureless, कोई suture नहीं होगा. And remember, ideal time for the congenital cataract after the 1 month, not the immediate. Please remember, it is not the immediate, it is after 1 month. Please remember, after 1 month. And what is the gold standard cataract surgery? It is the your phacoemulsification. Phacoemulsification. Now, what are the complications of the cataract surgeries? The most dangerous is the your end ophthalmitis. Okay, your end ophthalmitis, which is the most dangerous. Yes, if after the cataract surgery the patient is getting the end ophthalmos, the mentioned end ophthalmos, yes, eye ka end ho gaya, right? So the patient will be getting blind. The surgery's failure rate of the surgery will be the moreover if the patient is end ophthalmitis is having. The treatment of this is the having the intravitreal antibiotics should be given in this patient. Of course, the antifungals, amphotericin B and your varicozole, right, we are giving. If the only, if the patient is having the, only if the vision is having more than the hand movement, we are doing it. If the vision is less than the hand movement, so we have to do the pars plana vitrectomy. We have to remove the total vitreous should be removed from there, right? What are the cause? Please remember, the immediate cause is the your staph epidermidis, and the later onset is the your Bacterium acne or the fungal, right? Propionibacterium acne or the fungus can be also cause this and ophthalmitis, right? The features will be finding here the hypopion, corneal edema, and no fundus glow will be seen over there, and the decrease in the vision, and the patient is having the pain. Yes, the pain is the key feature of the end ophthalmitis. Please remember, the pain should be present over there. Okay, pain should be present over there. Also, This is the most dangerous, but not the most common for the and ophthalmitis is not the most common. But what is the most common for the long-term case, which is the your posterior capsular opacifications, right? After the cataract surgery, the patient is having the opacities. After the long term of it, the patient is getting the opacities on the posterior capsule, right? Posterior capsule पे क्या हो जाएगा? Opacities will be seen over there, and this is the your most commonly. And in this patient is having what? The patient is having the iris pulse should be there. ऐसा लगेगा something is floating inside the eye, and the patient is having the sommering rings will be there, and diffuse opacities can be found over there. But it is very easy to treat it. What is the treatment over it? Please remember for it, we have to use the Nd:YAG laser. With the using the Nd:YAG laser, will do what? Will do the posterior capsulotomy. Will do what? Will do the posterior capsulotomy. And Nd:YAG laser having the wavelength of the 1064. Yes, 1064 nm of the wavelength the Nd:YAG laser is having. The other Nd:YAG indications are the peripheral iridotomy we are doing for the with the your Abraham lens. It means when we are whenever we are putting the lens into the anterior chamber. So prophylactically, we are doing for this peripheral iridotomy should be done by the Nd:YAG laser. That should be done. That should be done, right? The next we are talking about the subluxation of the lens due to the trauma it can be due to the maybe the golden crescent sign will be present over there and iridogenesis will be present. The treatment is the removal of the lens. Yes, if the subluxation of the lens journals are break down and the lens is now in the posterior segment. Just think about it. If the lens is the posterior segment, what should be the treatment? Yes, of course, we have to remove. We have to remove the lens. This is the best thing which we have to do in this treatment. Yes, we'll remove this lens. After that, we can put in the artificial lens. Right, aphakic lens we should be put it in this condition. What is the key point is saying over there? Please remember endophthalmitis. Yes, this is the most dangerous, which is the cause. Immediate cause is the your staph epidermis. What is the posterior capsular opacities are the most common long-term complication. Okay, after many times, like immediate नहीं होगा. The posterior capsular opacities are the not the immediate. It is after the 2 year, 4 year, 5 years, right? And we use it for the capsulotomy. Yes, posterior capsulotomy is by the Nd:YAG laser, and the wavelength of it is the 1064. Please remember about is the wavelength of it. And here we finish the topic of cataract. So till now we done with the two important topics. Anatomy is done, right? Anatomy is done, anatomy of the eyeball and the orbit is done. Then we completed the lens and the cataract with the cataract surgeries topic. Any doubt, guys? If you have, please mention me in the chat box. I think the speed is good, right? Or should I decrease or increase? Let me know in the chat box. Is it the speed is okay? Chalo. Perfect. Done, done. Very good. Perfect. Chalo. Now, moving forward for the next, which is the glaucoma. Again, the glaucoma, we are getting the questions from the glaucoma every year. So, we have to talk about the types of the glaucoma, diagnosis of the glaucoma, and the treatment also. The frequently question they are asking to it. So, what is the glaucoma? Basically, the definition of the glaucoma is saying it's the group of conditions with the chronic progressive optic neuropathy, right? And the important key feature is here, which is the increasing intraocular pressure, increasing in the intraocular pressure. Okay, and yes, it is a modifiable factor. That's why we are going to modify going to it in this condition. And the first of all, we have to talk about the aqueous humor dynamics. As we show in the starting of the today's class, we talk about the aqueous humor dynamics, how the aqueous humor will be going to flow, how the aqueous humor will be going to produce, and this total pathway, right? So aqueous humor is producing from the your ciliary body, as we talked about it, ciliary processes. After the forming it, please remember, formed from the non-pigmented ciliary epithelium, and this is secreted via the sodium potassium ATPase pump. And the ultrafiltration of the aqueous is done by the ultrafiltration, and the diffusion also it's the contribution by the your aqueous humor. The rate of formation is the 2 to 3 microliters. Please remember 2 to 3 microliters per minute. The rate they can ask to you, and this is the formation. Dynamics is the formation of it. Now, if we're talking about the outflow, Please remember, which is the outflow pathway. How it will be getting outflow? So we have the two type of the outflow pathway. The first one, which is the conventional, which I shown you, which is the trabecular one, and also we can say from the through the angle of anterior chamber. Yes, it is draining from the angle of anterior chamber and also the trabecular meshwork. Now, trabecular meshwork se hoga, right? The rest, the second one, which is the very less, just the 10%, which is the your uveoscleral. What is the mean of uveoscleral? Yes, it can be absorbed by the uvea and then it is drained into the your scleral vessels, right? That is your uveoscleral. Just 10%. It is just 10%, which is the your uveoscleral. The next, if I'm talking about the classification of the glaucoma, this is a very, very important topic. Please remember, it is divided into the three types. The first one, which is the primary type. The second one is the congenital, and the third one is the your secondary type of it. In the primary, we have the two type of it. The first one, which is known as your open angle glaucoma, and the second one is the your angle closer glaucoma. Yes, angle closer. What is the mean of angle closer and open angle? Please remember, in the open angle, the trabecular blockage. Okay, the trabecular blockage. Yes, the trabecular meshwork is getting blocked by the proteins or maybe by the sclerosis, right? So that is known as your open angle. Angle to open hai, but trabecular meshwork mein dikkat hoga. Is it clear? Angle closer, that will be the pupillary block. Yes, so the pupil is getting attached with the lens. So pupillary block ki wajah se, due to this pupillary block, the patient is having what? Angle closer glaucoma. Angle closer glaucoma. The next we have the congenitally. Yes, it is the true congenital. In the infantis, the or the in the less than 3 year of the age, or in the it can be the juvenile also, right? The secondary, that can be due to the other systemic conditions, right? That is not related to this. Other can be the ocular or maybe the systemic diseases can be there. So that is called as the secondary type of it. Okay, is that clear? Now, if we talk about the risk factors of your glaucoma, so the most common risk factor, the first of all, is the age. The age for the more than 40 years for the your open angle glaucoma, and angle closure is seen in the more than 50 year. Okay, so at the more than 40 years open angle, more than 50 years close angle. Is it clear? Now, moving forward for the next, just a minute. Yeah, moving forward for the next, which is the for the refractive. Yes, glaucoma is having also the some refractive factor, risk factor, like high myopia patient is having the open angle glaucoma, and hypermetropic patient is having the angle closer glaucoma. Why the hypermetropic patient? As the patient is having the thick lens in the hypermetropia, the patient is having the thick lens, so it is having the easy to get the pupillary block, easy to get the pupillary block. So that's why the patient is having the patient is having the hypermetropic patient is having the angle closer glaucoma, right? The other factor, if I'm talking about of the risk factor, that are the family history, diabetes, hypertension, steroid uses, trauma. These are the your miscellaneous miscellaneous risk factors over there. If we talk about the FMG key point, very important, please remember the aqueous outflow की बात करें, so 90% please remember the conventional or we can say the trabecular meshwork, right, through the trabecular meshwork. The rest 10% is by the uveoscleral. The rest 10% is by the uveoscleral. The rate of the filtration, if we're talking about the formation of aqueous humor rate, is the 2 to 3 micro liters per minute. And the high myopic patient, please remember, if the patient is having the high myopia, just remember about it. High myopia patient is having the posterior open angle. Please remember, primary open angle glaucoma, and the hypermetropic patient is having the primary angle closer glaucoma risks, right? So myopia में open angle होगा, ठीक है? Hypermetropia में angle close होगा, angle closer होगा. Is it clear, guys? Yes, please remember glaucoma topic is very important, and we expect every year one MCQ from here. Yes, yes, it's sure. One MCQ 100% from here. ठीक है? होगा ही होगा glaucoma से, cataract से glaucoma से होगा ही होगा. Now, for the glaucoma we need to the IOP changes. हमें देखना पड़ेगा. For the glaucoma we have the feature. In the glaucoma we have the three features, है ना? Glaucoma का भी हम triad बोल सकते हैं. What are the three main features? Increase IOP should be there. Okay. The second one, the disc feature. or we can say the disc sign. ठीक है ना, डिस्क पे कुछ साइन दिखने होंगे हमें. एंड द थर्ड वन विच इज द विजुअल डिस्टर्बेंस, और वी कैन से द विजन लॉस, है ना. विजन लॉस में होना चाहिए, विजुअल डिफेक्ट होना चाहिए. विजुअल डिफेक्ट शुड बी प्रेजेंट ओवर देयर. फॉर डूइंग इट, फर्स्ट ऑफ ऑल वी टॉक अबाउट द इंट्राओकुलर प्रेशर. आईओपी के बारे में बात करेंगे. सो इन द इंट्राओकुलर प्रेशर वी हैव टू मेजर बाय द टोनोमीटर. नाउ वी हैव द मेनी टाइप ऑफ टोनोमीटर लाइक द शिजॉट्स, we have the Goldman application tonometer, we have the tonopen, we have the non-contact, we have the plasca, we have the rebound. Now बहुत सारे टोनोमीटर्स आ गए which we have to use. कब कौन सा यूज करना चाहिए and what are the principle of it? Please remember about it. The principle of the Shizot is have the in head your indentation, and this is we have to touch this scissor on the patient's cornea, है ना. पेशेंट की कॉर्निया पे हमें टच करना पड़ेगा. Remember about it. So this is the depend on the scleral rigidity, and this are less reliable. This is not so much reliable. इसको हम इतना reliable नहीं मानते scissors को. The next we have the Goldman applination tonometer. This is the work on the applination, and this is the most reliable. So that's why it is the gold standard. Please remember about it. So if they're asking you which is the gold standard tonometer, yes, it is your Goldman. Okay. So नाम भी gold standard, नाम भी Goldman है और standard भी gold है, right? So this is in the fixed area, just by the 3.06 mm should be touching on the cornea, not the full cornea. The next we have the tonopen, which is having the working on the applination. Again the same applination principle, but it is portable, and this is the every time we have the choice for the children, or we have this like maybe sclerid or maybe the irregular cornea like keratoconus. ठीक है, keratoconus. In such cases we are using the tonopen. We are using the tonopen nowadays. Most commonly we are using like most common used. Okay. Yes, the gold standard is the Goldman, but nowadays we are using the non-contact because there is no need to touch over the cornea. This is working on the air puff, right? So the air pressure is coming into the eye. Whatever the pressure is getting written over there, that is measured. And in this condition, no anesthesia is needed, and it is a screening test. Okay, it is a screening test. Please remember, no anesthesia is needed. Please remember, no anesthesia is needed. Rest of all, बाकी सब में ये सिजॉट हो गया, गोल्डमैन हो गया, टोनोपेन हो गया, we need the anesthesia because we have to touch this instrument on the patient's cornea. So when we are going to touch this patient, the patient is getting the irritability, right? So that's why we are giving the anesthesia eye drop, okay, in the topical form, right? In the topical form, we are giving the anesthesia. But in this non-contact, we don't have to use any anesthesia in this condition, right? Chalo. Moving forward for the plasca, this is working on the dynamic contour, and this is the least contact type, right, which is the independent of the CCCT, right? But we are not using it. Yes, rebound we are using, which is the introduction, of the rebound as the name of rebound. इसलिए उसका principle is also the rebound, and we are using this for the your self measurement, right, which is the eye care tournament. It means the patient is frequently having the glaucoma and frequently increasing the intraocular pressure. So patient बार-बार तो नहीं जा पाएगा ना ophtha clinic for the getting this tonometer, right? So that's why we give to this patient, and the patient is doing by self, okay? Self measurement, right? Patient can do the self. As you know very well, which is the known as normal tension in glaucoma. This is the topic of it. Please remember what will be happening in this condition, right? As we talk about this, all the three, out of this three, this is not present. It means IOP is normal. If IOP is normal and rest 2 is present, we say it the normal tension glaucoma. Please remember about it. It is known as normal tension glaucoma. So the IOP is the normal 10 to 21 mmHg, but the fundus change is present and the visual field defect will be present over there. And this is the vascular theory is the independent blood supply to the nerve, right? So this is depending on the vascular theory, but please remember the field changes and the disc factor, like we can say the disc sign, okay, na? Disc changes, fundus changes should be present over there. So we can say the normal tension glaucoma. The next we have the ocular hypertension. Please remember what will be happening in this condition. In this condition, the patient is having the increasing the IOP, but the fundus seems normal, no visual defect the patient is having, yes, the patient is risk to progression to the glaucoma. Maybe it can be the patient can be reached to the glaucoma. अगर आगे IOP should be remain increased, IOP increase रहेगा, so it can go to the fundus changes and visual field defects can come. So that's why we have to treatment is the if the patient is having on the high risk of the glaucoma, like features already we talked about it, all the high risk factors. So we should have to treat this ocular hypertension, right? Now the FMG key points we are having. Every topic, every slide have the FMG key points. Just before going to exam, you have to scroll. For the ophthalmology, you have to just scroll this PDF. Also, you have to just go through this all the FMG key points, right? That's very, very, very important. All the topics are compiled in this PDF, right? In this session, right? Chalo. Moving forward for the next, yes, the next one is the your just a minute. You have to just go through this. Now we are going for the next one, the FMG key points. Yes. So the FMG key points are mentioned over there, which is the Goldman application tonometer is the most reliable. If we're talking about the most reliable concept, so this is the Goldman application tonometer. What about the tonopen? This is for the choice for the children. Yes, we are using the tonopen for the choice for the children. Normal intraocular pressure is 10 to 21 mm Hg. Yes, normal intraocular pressure is your 10 to 21 mm Hg. Is it clear? Right. Chalo, moving forward for the next. Just a minute. Moving forward for the next, yes, what will be the fundus changes and the visual field changes will be seen in the glaucoma, right? So you can see over there, as we can see over there, this is the normal healthy optic nerve, or we can say the fundus, and this is the optic nerve with the eye with the glaucoma. So you can compare the changes over there. Yes, you can compare the changes over there. You can see in the changes, right? Very dramatical changes will be seen over there, and you can find out, right? You can find out there that what are the changes on the fundus. Very important. What are the fundus changes? So the first of all, as you know, there is an optic disc and optic cup is there. So there will be the increasing in the cup size. Okay. So first of all, as the cup is there, so as the cup will be getting increases, so this cup size will be getting increases. So cup size increase hoga. So what will be happen? There will be the cup disc ratio will be increasing. So what will be happening in this condition? As the cup will be increasing, so the cup disc ratio will be getting increased. The next we are talking about the what will be happen? There will be the nasal shifting of the vessels. There will be the nasal shifting of vessel. There is a nasal shifting of the vessel. You can see over there all the vessels are passing throughout the your optic disc, and what will be happen in this condition? All the vessels are shifted to, okay, all the vessels are shifted to the your towards the nasal side. Like this is the nasal side. If I'm looking on this fundus on the right side eye of the fundus, so this all will be shifted to the nasal side. If I'm looking on the left side eye, these are also shifted to the your these all are also shifted to the your nasal side, right? Next we are talking about the your Banot signs. What is the Banoting signs? There is a sharp vessel bending. What is the mean of sharp bending? Yes, as the normally they are passing through it, but now what happened as they are pushed towards the nasal side, so there will be the sharp bending will be going to seen over the yes on the Banoting sign, right? Banoting sign. Also, we have the overpasses phenomena where the vessel can cross the rim, and of course there is a that's why the third feature is we can say the thinning of the rim, right? Thinning of neural retinal rim. And what is the mean of this neuroretinal? Just remember about it. This is the cup and this is the disc. So this gap between the cup and disc, this is known as the neuroretinal rim. As this will be getting increases, the cup size will be increasing. So this neuroretinal rim will be getting thinning, and this is known as your overpasses phenomena. So the vessels will be crossing the rim. This vessel can cross the rim, right? Last, which is your peripapillary atrophic papillary. The peripapillary atrophy can be seen in this condition of the your optic nerve can be atrophied over there, right? So these are the your fundus changes which will be over there. The markedly we are talking about it. So there should be the increasing cup size, the nasal banding, and your thinning of the neural retinal rim. If these three are there, that is very, very important. Also, the Banotting sign and this overriding, the overpasses phenomena, this also should be presented over there, right? This can be presented over also there. Now, if we're talking about the visual field defect in this condition, if we're talking about the visual field defect in the glaucoma, so there can be the two type of it. The first, the early and the late. So if we talk about the early, in the early, what we'll be going to find? In the early, there is a Berger's scotoma. What we'll be going to see? There is a Berger's scotoma will be seen. And what is the Berger's scotoma? The patient is having the nerve fiber bundle defect, and the paracentral scotoma should be there. The Bergeron is what? Just only the one half quadrant is updated. Like the nasal strap should be there, or maybe there is increasing of the your blind spot can be seen over there. But in the later stage, the patient is rest with the tunnel vision. Only the central part of the vision, or the we can say the tubular vision, is rest in this patient, right? So these are the, please remember, the visual defects are the progressively defects. Okay, if it is started, they will be going to progress. We have to treat this patient. And please remember, whatever the visual field defect is happened in the glaucoma, we cannot reverse it, because this is related to the nerve fiber bundle is getting defected. Okay, so if the nerve is getting damages, right, nerve में damage हो जाएगा, so that cannot be get back, है ना? Vision जो defect हो गया, that should be, the patient should be remain with it. Okay, patient should be remain with it. Now, starting with the in the types of it, angle closure glaucoma and the congenital glaucoma. So just remember about it. In the angle closure glaucoma, we have the angle closure glaucoma is having the mechanism is the pupillary block. This pupil will be getting what? Just look into it. This is your lens, and this is your pupils. Okay. So this is the pupil, which is we can say the iris, right? So what will be happening over there? This is like banding of, because of maybe due to the large lens, we can say, or due to the pupillary, this pupil is making synecdoche with this. And as they make with the synecdoche with this, now this is attaching over there. So now what will be happen? Please look into this condition. Now this, as it is getting attached to this, due to the aqueous, this aqueous will be going to push this iris towards forward. We can say the forward. And what will be happen with this? Due to this, what will be happen? This angle, right? This angle of anterior chamber is getting close. The angle of anterior chamber is getting close. And what will be the patient having the symptom? Please remember, the severe pain and blurring vision, right? The sudden hoga. Please remember, halos and the aroused lights will be there, and the nausea vomiting will be there because of the sudden increasing in the intraocular pressure. And the sign will be seen, there is the streamy cornea, shallow anterior chamber will be seen, and fixed mid dilated pupil. Please remember about it. If the question, the keyword, this is the key word, right? If the patient mentioned the question in the question, clinical question, they mention about it, the patient is having the painful degrading, slowing, blurring of the vision, severe pain, they are vomiting, and there is a fixed mid dilated pupil. So the answer should be your angle closure glaucoma, right? The congenital glaucoma, also the congenital glaucoma is also having the triad, which is the you have PLB. What is the PLB? The photophobia, lacrimation, and the blepharospasm, involuntary closing of the your eyelids, like blepharospasm. So this will be the triad will be going to seen over there. What is this? Yes, this triad will be remain in the congenital glaucoma. In the congenital glaucoma. Now, other features will be, of course, seen will be the ophthalmos, which is the ox eye, or we can say the bull's eye. Okay, ox eye, or we can say the bull's eye. Also, there is a hub stria, which is seen in the descendant membrane breakage. There will be going to seen. Also, the corneal clouding and increasing in the corneal diameter will be seen in the congenital glaucoma also. Now, if we talk about the treatment of the your, if we talk about the treatment of the your uh, primary angle closure glaucoma. So there is a category. The systemic drugs and the topical drugs should be used. So in the systemic, we have to give the IV mannitol or the oral glycerol, which will be should be given first. Okay, we have to give this first. Okay, पहले हम systemic drug देंगे, IV mannitol or the oral glycerol, to decrease the intraocular pressure, and the action should be here the as is the osmotic agent, you know very well, it will reduce the vitreous volume. It will do what? It will reduce the vitreous volume. The tropically, if we're talking about it, the tropically, there will be the pilocarpine, which is the should be given the second, and this is the your we can say the drug of choice. Yes, drug of choice for the angle closure glaucoma is the your pilocarpine. Also, we can give the temolol or the your brimonidine. These are the mitotic and the beta blocker and the alpha agonist drugs. So they will this pilocarpine will do the breakaging of the pupillary blockage. Right now, as we talk about the your FMG key point, please remember the congenital glaucoma triad is having the photophobia, lacrimation, and ophthalmos blepharospasm. Please remember the ophthalmos is the your bullseye, and the herbs striates the descendant membrane breakage seen in the congenital glaucoma, So here we finish with the related to the all the questions or the important topics which are frequently asked from the topic of glaucoma. Any doubt in the guys? Any doubt in this glaucoma topic? Any doubt, guys, in the glaucoma topic? No? Good. Perfect. Let's move forward. Let me know in the chat box. Is the speed is okay, guys? As we done with the three, yes, we done with the three topics. So let's move forward. Perfect. Let's move forward for the next topic. Just a minute, guys. Moving forward for the next topic is the your yes. The next topic we are starting with the cornea. Right now we are moving forward for the next topic, which is the your cornea, and starting the cornea with the first of all the corneal anatomy and the layers of the cornea. Right. So as we started with this, the layers of the cornea. So you can see the structure of the cornea, and as we go for the anterior to posterior, it is having the 6 layers. Okay, how many layers? 6 layers. The first of all, we have the epithelium layer. You can see over here, this is the first one, which is the epithelial layer, which is we can see the outermost. And please remember, it's regenerated in the 24 to 48 hours, right? It regenerates the, yes, it can be regenerate. Okay, epithelium can be, this corneal epithelium can be regenerated into the 24 to 48 hours. Moving forward for the next is the your Bowman's layer, and please remember about it, it do not regenerate, right? Bowman's layer will be not going to regenerate. Yes, Bowman's layer will be not going to regenerate. The next, moving forward for the third one, which is the your stroma layer. Yes, which is the your third one, which is the your stroma layer, and yes, this is the your thickest layer. The 90% of the cornea is the your stroma. Yes, so 90% of the cornea is your stroma. The fourth one is your Duas layer, or we can say the predescent membrane. And the fifth one, we have the descent membrane, which is we can say the toughest layer. We can say the toughest layer. And the descent membrane regenerates, right? It also regenerates. Clear? Next, endothelium. This endothelium do not regenerate, and it have the sodium potassium. It also have the sodium potassium ATPase pump, and this one will be the sodium potassium ATPase pump, which is the endothelial cells, which is having the giving the nutrition to this cornea through the aqueous humor. Through the aqueous humor, it is getting the nourishment of it, because the cornea is also the guys avascular structure. Remember about it. So the key factors are here the avascular to maintain the transparency. Yes, this is the avascular for the transparency maintenance, right? So the transparent रहेगा cornea, and endothelial cells की अगर हम बात करें, so there is a 3000 to 4000 square at the birth, right? So these are your corneal endothelium cells. Right now, what are the parameters of it, and what are the values are given to it for the what will be the remaining with the clinical significance? So the central thickening of it should be the 520 microns, right? If it increasing in edema and decrease in the your ectasia, right? So increase कब होगा? Edema के अंदर increase होगा and decrease होगा in the ectasia like your keratoconus, right? It decreases in the keratoconus. The refractive power is here for the cornea is the 43 to 45 diopter, and this is the major refractive component of the eye. Please remember, it is the major refractive component. Two components of the this refractive power we are having. What are those the two refractive power for the values? We have the cornea and the lens. So the major one is the, yes, 43 to 44 diopter. The rest 16 to 17 diopter is done by your lens. Clear? The clinically, if we're talking about your critical endothelium, is the if it is less than 500 to 800 mm square, this can cause the corneal decomposition or the corneal edema will be going to seen over there, because this will be not getting the corneal cells is not over presented over there. So the nourishment and the nutrition of this cornea should be not going to present, and this the fluid can be accumulated inside the cornea and it can be getting adenomatous and the opaque also. Now, what are the FMG key point is saying? The cornea is avascular, as we already talked about it, and the your critical cell count is the your less than 500 to 8 mm cause edema. And remember Bowman, please remember Bowman's layer also not regenerate, and which also not regenerate, yes, endothelium. Bowman's and endothelium. Okay, so Bowman's and endothelium is not getting regenerate. So after of this layers, yes, endothelium में तो cells regenerate होगी ही नहीं, right? And if we talk about the layers पे, so in the layers there is the Bowman's layer will be not getting regenerate. Clear? So out of this, all the 6 layers you have to remember, yes, the duas is also added over there. If you're seeing in the image, आपको 5 पे दिख रहा होगा. I know. So just remember, before the Descemet membrane, there is a small layer, thin layer which is present, which is known as pre-Descemet membrane, which is also known as the Duas membrane, which is also known as the Duas layer or Duas membrane. Clear? Moving forward for the next, which is the your infectious of the your cornea. Yes, so infections of the cornea is known as your keratitis. Yes, the infections of the your cornea is known as your keratitis. Yes, it is known as your keratitis. So let's talk about the keratitis now. In the keratitis, we have to talk about the first of all, we have to talk about the your three type of keratitis is mentioned over there. So first of all, we mentioned the herpes simplex keratitis. Then we have to talk about the herpes zoster keratitis, and then we have to talk about the acanthamoeba keratitis. Now, starting with the first one, right? As is the all the infections. So as you know, the most common cause of the infection keratitis is the your is the herpes simplex keratitis. In this herpes simplex keratitis, we are going to see the dendritic ulcer, which is having the branching and terminaling of this bulbs. Also having the geographic ulcer in the later stage, this the enlargement of the dendrites will be seen in the geographical ulcer, and we can see there will be the disconfirm. This is the having the type 4 hypersensitivity and endothelium. And please remember, in the treatment, this we have to use the acyclovir 3% for the 5 times a day for the 14 days. Please remember, for the 14 days. Over the treatment, we have to see there can be the metanephric keratitis can be there. And please remember this, all of the key feature is the herpes simplex is your painless keratitis. Okay, so अब painless है तो patient कब आएगा? When the patient is having the blurring vision or having the visual disturbance in the herpes simplex keratitis, so the patient can come to the or in to come to visit the ophthalmology clinic, right? So this is about the herpes simplex keratitis. Yes, the treatment should be, please remember, the treatment should be your acyclovir 3% eye ointment 5 times a day should be given for the 14 days. For the 14 days. Next, the herpes zoster, it is followed by the your V1 dermatome distribution. There will be the your Hutchins sign should be tip present. The tip of the nose lesion, which is known as the nasociliary involvement, should be present over there, which is the Hutchinson sign. Also, there is a pseudodendrites will be going to seen. There is no terminal bulbs, only the pseudodendrites should be seen over there, and the stain poorly with the fluorescent dye when we are going to put it over it. And in this condition, the treatment should be given the oral antiviral or the topical antiviral should be given in this herpes zoster keratitis. We can go give with this. Next, acanthamoebal keratitis. Please remember, this is the soft contact lens plus tap water users. Like if the patient is having the can be caused by the soft contact lens, the patient is washing with the tap water or the washing of the eyes with the tap water, it can cause. And please remember, there is a ring lesion will be seen over there. We can say the ring ulcer, right? हम इसको क्या बोल सकते हैं? Ring ulcer. Okay, ring ulcer will be going to seen over there. Also, we can say this is you're having the disproportionate pain because of the neuritis. Okay, the patient is having the nervous involvement of this acanthamoeba, so we can say the disproportionate pain, more pain, severe pain will be there. Also, we can say the peritonitis will be seen. There is a thickening of the corneal nerves will be can be seen over there. The culture will be show on the non-nutrient agar with the E. coli. We can do the culture over there. And yes, the treatment is the drug of choice is your PHMB. Yes, we have to give this patient to this for the acanthamoebal. Yes, the symptomatic treatment should be given like painkillers and all, as the pain is more over there. We can give, but the drug of choice is your PHMB should be given to this patient. All right. Moving forward for the next. The key points. Yes, we have to talk about the first of all key points. In the key point, the HSV is the dendritic has the terminals, but in the HSPS, herpes simplex. But in the herpes zoster, there is a no dendrites. Please remember about it. The Hutchinson sign and nasociliary involvement is seen in the your herpes zoster virus. And please remember in the acanthamoebal, the contact lens users are having the ring lesion and the severe pain. Please remember severe pain के साथ आएगा in the patient of acanthamoebal keratitis with the ring ulcer. Yes, of course, the history of misusing of contact lens should be presented over there. Interstitial keratitis and the keratoconus. Let's talk about this interstitial keratitis also. So the epithelium and endothelium are the normal. Only the stroma is getting involved. Now the causes are the syphilis, TB, leprosy, your sarcoidosis. This is the Kogan syndrome. It is having the what interstitial keratitis plus your deafness, and the Salmon patches will be seen in the your stromal bleeding in the syphilis cases, right? In the cases of syphilis, of course, the treatment is your underlying cause plus steroid. Please remember in this case, what we have to give, we have to give the underlying cause. Like if the underlying cause is the your leprosy, so we have to should treat the leprosy or the syphilis. Also, we should give the steroid in this condition for the interstitial keratitis. What about the keratoconus? As we talked about it, the keratoconus is your eclectic dystrophy, which is the genetic having the progressively increasing in the curvature of the cornea, right? So the in this condition, if we're talking about it, it is increasing the curvature and decreasing the we can say increasing in the curvature and decreasing in the corneal thickness. Yes, so corneal thickness क्या हो जाएगा? Decrease हो जाएगा. Now this is having the irregular astigmatism, which is the marked visual loss will be appearance over there. What are the important features we'll be going to see? There is a Munson sign will be seen in the when we are saying to the patient with the keratoconus to look downwards. It is having a this cone, right? This cone will be having a depression over the lower lid. Okay, depression over the lower lid. This V sign we are saying on the Munson sign. Also, the patient is having the Flesher's ring. What is the Flesher's ring? This is the iron base at the cone, right? So, what is this is the cone, right? As it is increasing the cornea curvature. So, this cone is having the deposition of the iron over here, right? This is iron, right? So, this is having the Flesher's ring. This is the Flesher's ring. Also, the oil droplet reflex seen on the distant ophthalmoscopy. Yes, distant direct ophthalmoscopy. Please remember when we are doing the distant direct ophthalmoscopy, we have to see the normally with the red glow. है ना? Normally क्या present होगा? There will be the normally the present of the red glow will be presented over there. Right? Very good. Let's talk about it. In the keratoconus, all the signs we have to talk about it. The Munson sign, which is we already talked about it, which is the V-shaped lower lid deformity, and this yes, of course, if the Munson sign is present, the treatment part you know very well. In this condition, we can like treatment part later on we talk about it. The Flesher's ring is the iron deposition at the cone base. The scissor reflex on the retinoscopy when we are going to do, and your prominent nerves, the corneal thinning will be the vulnerable. The treatment should be done in this condition. The progressively we have to give the C3R and CXR, which is the collagen cross linkage surgery can be do. We can give the contact lens, which is your RGP, rigid gas permeable lens should be given in this condition. Also, we can advise for the penetrating keratoplasty, and we can do the deep laminar keratoplasty should be done in this case of the treatment of the your keratoconus. The FMG key point is saying here the keratoconus sign, which is your Munson sign, you have to remember, the Flesher ring you have to remember, and the oil drop reflex should be remembered. The treatment, please remember C3R corneal, corneal collagen cross linkage with the riboflavin should be done in this case, which is your C3R CXR surgery should be done. Yes, C3R. Please remember about this collagen cross linkage with the riboflavin should be done. Is it clear, guys? So this is the treatment of the your corneal keratoconus, corneal keratoconus. Let's move forward for the next topics, which is your conjunctiva, right? So just all of the rest topics we are doing, right? So done with the glaucoma, done with the your cataract, done with your anatomy, done with your cornea. The main important topics are covered, right? Chalo. Now moving forward with the conjunctiva. Yes, now we are moving forward with the just a minute. I'm checking all the comments. Good. Okay. Now we are moving forward for the conjunctiva, right? Now, the conjunctiva is very important, starting with the first of all, the types and the feature of the conjunctivitis. The most commonly they are going to ask you the conjunctivitis, right? थोड़ा सा यहाँ पे confusion हो जाता है conjunctivitis में, so we'll talk about it. The types of the conjunctivitis, we are having the bacterial type of conjunctivitis, we have the viral type of conjunctivitis, allergic conjunctivitis, chlamydial, and the membranous. So we have to talk about this all of the type of the conjunctivitis and how we can differentiate with it, right? And what are the causative organisms of those particular bacterial, viral, allergic, right? So we have to talk about it. So the first of all, the discharge. Yes, they all have the different discharge. Like the bacterial will be having the purulent and the mucopurulent discharge. The key feature, the patient is having the papillary response on the rapid onset, right? The patient is having the papillary response on the rapid onset. The causative organism are the strep and the your staphylo, H influenza and the gonococcus. Yes, streptococcus, staphylococcus and the, your H influenza and the gonococcus. Yes, gonococcus can be causing this. Now, talking about the second one, which is their viral one. In the viral, the patient is having the discharge watery and scanty. Please remember, the patient is having the watery and the scanty discharge. And the key features is here, the patient is having the follicle, uh, the patient is having the follicles and having the pre-auricular lymphadenopathy. The patient is having what? Pre-auricular lymphadenopathy. Yes, the adenovirus is the most common cause in the viral, and your herpes simplex virus or the enterovirus 70 is also the causes of your viral conjunctivitis. In the allergic condition, please remember the discharge is the watery and stringy, right? We can say the ropey discharge, right? Stringy. And the patient is having the key feature of the itching in the itching and the papillae will be the bilateral. And the causative organism is not over there, but what is the hypersensitivity type 1 by the pollen, dust, or maybe mites due to the allergens. This is due to the allergens. In the chlamydia, we have the mucopurulent discharge. The patient is having the mucopurulent discharge. The follicles on the superior dorsal will be visible. And yes, the causative organism is your chlamydia trachomatis from ABC and the C and DK, right? ABC and the D2K is the types of the chlamydia can cause the conjunctivitis, which we say the trachoma, right? जिसको हम बोलते हैं trachoma. Chlamydia if involved in the conjunctivitis, we say the trachoma. The next we have the membranous, which is having the scanty, which we have this scanty discharge. These are the true membrane present. And please remember, it will be getting bleed out. If we are peeling this membrane, yes, one membrane will be covering over the cornea. As we are going to peel out this membrane, it will be starting bleeding. Okay, and this is by the Corynebacterium diphtheria. Please remember about it. The membranous will be by the Corynebacterium diphtheria. Right now, the membranous and the pseudomembranous. There is a difference. Yes, we have to talk about the membranous and the pseudomembranous. Please remember the two membrane will be bleed on the peeling, which is by the diphtheria, and pseudomembranous does not bleed on the peeling, right? It can be does not on the peeling. And what are the causes of the pseudomembranous? Is the adenovirus, or streptococcus or the herpes simplex virus. Please remember, in the diphtheria treatment, we have to give the anti-diphtheric serum. Yes, in this case, we have to give the anti-diphtheric serum. So, हमें क्या करना होगा? How we can get to understand this is the membranous or pseudomembranous? ठीक है, for the making the diagnosis, we have to just peel out. थोड़ा सा peel out करके देखना होगा. If it is getting bleed over the peeling of it, it means it is the true membranous. And if it is not bleeding, it is the your pseudomembranous, right? It will be called as your pseudomembranous, right? Chalo, moving forward for the next. Just a minute, guys. Just a minute. Just a minute. Sorry for this disturbance. Am I clearly audible and visible? Let me know in the chat box. Am I clearly audible and visible? Yes. So in the membranous and the pseudomembranous, yes, we have to peel out this membrane. We have to check it is a diphtherial or maybe the other causes. Pseudomembranous should be treated in the different way. If there is a diphtherial, is the true membranous, then we have to give the anti-diphtherial serum should be given in this cases. Moving forward. Now, the moving forward for the next one, which is your hemorrhagic conjunctivitis, right? We have the next one, which is the causes by the hemorrhagic conjunctivitis. In the hemorrhagic conjunctivitis, we have the subconjunctival hemorrhage plus conjunctivitis. Please remember, the patient is having the conjunctivitis plus your patient is having the what? Your subconjunctival hemorrhage. The cause is your enterovirus 70, which is the most common cause. Yes, which is the most common cause. Also, it can be caused by the adenovirus or the Coxsackie if 24 virus. Yes, it is a self-limiting, but it is a very highly contagious. Yes, it is self-limiting conjunctivitis, but it is a highly contagious uh, conjunctivitis. Now, talking about their FMG key point, please remember the true membranous, which is bleed on the peeling. It is a diphtherial. Pseudomembranous does not bleed. Please remember. The antivirus 70 is the most common cause for the hemorrhagic conjunctivitis. Clear? So this is if we're talking about it, the most common cause of hemorrhagic is the your antivirus 70. Remember about it. Let's move forward for the next, which is your trachoma and vernal keratoconjunctivitis (VKC). Right? The side by side, we have to talk about this both of this disease. Also, the trachoma is the caused by your chlamydia trachomatis serotype A, B, BA, and the C. Also, the DK cause in the causes the adult in your inclusion conjunctivitis. It including the conjunctivitis. The Herbert's follicle will be seen on the upper limbus, right? We have to see the patient. The Herbert's follicles will be going to see in white gelatinous sago grain follicles type will be going to seen over the Herbert's follicles. Also, we are going to see the Earth's line will be seen on the in the patients of the outline will be seen on the linear scars will be seen on the your conjunctiva, and also the Hubbard spits will be seen on the black spots will be going to seen over there. The WHO staging is saying the first stage is the follicular stage, second is the inflammatory, and third is the scarring, fourth is the tracheasis, and the fifth one is having the corneal opacities will be there. And the for the treatment part of it, we are using the safe strategy, as you know very well. S is stand for the surgery, A is for the antibiotic, F is for the, your facial cleanness, and E is for the related to their environmental hygienation. The treatment of choice, if we're talking about nowadays, the azithromycin, if prevalence is the more than 10%, right? So azithromycin we are giving in the antibiotic of the choice in this cases. Also, we have the next, we have the vernal keratoconjunctivitis, which is a VKC. Yes, it is due to the allergens, or we can say that this is due to the allergy. Okay, due to the some allergens. Okay, and in this condition, the patient is having the cobblestone appearance on the upper tarsal conjunctiva, and this is the exogenous. Of course, this should be the exogenous allergens like dust, pollens, mites can be there. But in this condition, please remember, you should remember about it. It will be always the male child and it is having the type 1 hypersensitivity. Yes, so the VKC is more commonly like involved in the males, not the females. Also, the patient is having the papillary hyperplasia in the upper tarsal limbus. Also, the patient is having here the Horner Tanta spot, HT spot, which is the eosinophils will be going to accumulate it at the limbus, right? And there can be the shield ulcer, which is the corneal complication. What is the shield ulcer? As the patient is having the cobblestone appearance over the conjunctiva. Yes, the patient, as we already mentioned, the cobblestone appearance will be the on the over the upper tarsal conjunctiva. So the when the patient is opening and closing the eyes, right? Whenever the patient is open and close the eye, what will be going to happen in this condition? In this condition, the patient is having the rubbing over the cornea and the cobblestones. Okay, due to this rubbing of it, there will be the epithelial erosion. सबसे पहले epithelium will be getting eroded, and the slowly it will be getting the your shield ulcer, which we can say the non-healing ulcer, right? It can be started as a non-healing ulcer. Also, there will be, we can say, the Capet's bow or the maybe the pseudo genotoxins can be seen over there, and toxon, and the descendant margin folds will be the on the lower lids, right? On the lower lid, we are going to see the Deneen Morgan folds can be seen over there. And the treatment, please remember about the treatment. If the patient is coming to you in the vernal keratoconjunctivitis stage, we can give the mast cell stabilizers, and the steroid can be given to this patient, or antihistaminics also will be given in these cases. But this case is having the recurrency, guys. Please remember about it. Okay, this is having the recurrency. Okay, what is the mean of recurrency? If the child, a male child or boy, come to you at the age of 6 years, right? So every year in the seasonal peak, it is having the VKC, right? And we have to give the mast cell stabilizer, steroid, and the antihistaminics, right? Of course, if the symptom is having antihistaminics, okay, so antihistaminics should be given in this cases. Now, what are the FMG key points are here? The safe strategies are for the trachoma. Yes, and please remember the VKC has the cobblestone appearance and the Horner Tanta sport. Yes, we have to remember. What is the shield ulcer? Yes, the shield ulcer is the corneal complication of the VKC. Yes, shield ulcer, which we can say the non-healing ulcer also, right? Shield ulcer को हम non-healing ulcer भी बोल सकते हैं, because again and again rubbing of this cornea, वो बार बार rubbing होगा cornea का, as again and again it is rubbing of the core, the cornea, the corneal epithelium is getting eroded, and it will be not getting healed, right? It will be not getting healed over there, right? Now, moving forward. Now, moving forward for the next we have the Factanicular keratoconjunctivitis and the bitote spot. Now, listen this part. For the factanicular conjunctivitis, please remember in the factanicular keratoconjunctivitis, it is having the hypersensitivity to endogenous antigens. Now, this is the endogenous. It is hypersensitive to the endogenous antigens. What are the causes here? The Staph aureus or the TB, and it is having the your type 4 hypersensitivity. For this Staph aureus, please remember the worldwide. The worldwide is the Staph aureus. And if we're talking about the India, in the India, we have the TB. Okay, most common cause is the tentacular keratoconjunctivitis, the TB. And we are going to find over there is a fascicular ulcer, or we can say the ring ulcer will be going to find over there. And in the treatment, we should give the steroids. Yes. And if the patient is from the India and having the TB, we should have to start the anti-tubercular treatment. ATT should also given with the steroid, right? ATT should be given in this cases, right? So that is related to about the factinocular conjunctivitis. Very important topics. Worldwide, Staph aureus. In India, it is a type. It is by the TB, and it is a type 4 type of hypersensitivity, which is late. You can say the right late hypersensitivity. What about the bitote spot? It is seen in the vitamin A deficiency, and this will be seen in the cases of like staging. If we're talking about the xerophthalmia staging of WHO is the X1B, right? Bitote spot will be going to seen. What is this bitote spot? They are the very foamy triangular shape on the temporal conjunctiva. There is the foamy triangular shape will be going to seen over there. This is the most common temporarily, right? This is most commonly temporarily and seen in the staging of X1B. Please remember the WHO staging X1B will be seen over there. The treatment should be here the vitamin A 1 lakh unit should be given on the day 0, day 1, and the day 14. The 3 doses will be given, right? 1 lakh, 3 doses will be given. Okay, vitamin A 3 doses should be given in this cases, right? And what are the WHO grading of the xerophthalmia is saying? That is saying the XN, it means that it is having the necrolopia. It means the night blindness is the earliest symptoms of the vitamin A deficiency. The patient is having the next stage, which is having the X1A. It means it is involvement of the conjunctiva. It will start with the conjunctival cirrhosis. So dryness, wrinkle of the conjunctivas will be patient will be going to facing. The X1B is having the now the biter spot. As we talked about it, the foamy temporal area conjunctival have the foamy lesion over there. Right on the conjunctiva, so that is the X1B. X2 is there for the now involvement of the cornea, so the corneal erosions will be going to seen, the dry and hazy cornea will be going to seen in this condition. The X3A and X3B is the having the keratomalacia. It will be the corneal melting will be going to seen in this condition. If corneal melting is less than 1/3 part, it is called as the X3A. If more than 1/3 part, that will be called as the X3B. Understood? The last one, which is the XS, which is having the your corneal scarring, as it is related to the scar. It is the your sequentials of the your is the ophthalmia. So this is the all this staging by the WHO grading, right? Now you have to remember for the FMGE key point, you have to remember the bite dot spot is the vitamin A deficiency seen in the WHO grading X1B. The treatment is the 1 lakh unit on the day 0, 1, and 14. Pectinicular conjunctivitis having the type 4 type of hypersensitivity in the worldwide it is the Staph aureus, and in the TB will be seen in the India. Cause, okay, remember the cause of it. These are the causes. The next we are talking about the next one. It is the your pterygium and the dry eye. Let's talk about the pterygium and the dry eye. It is also related to your conjunctiva, right? Starting with the your pterygium. The pterygium is what? The pterygium is the your connective tissue disorder, right? As we already talked about it, that conjunctiva should be remain on the scleral part, okay? Limbus तक रहेगा, है ना? Not covering the cornea. Cornea पे नहीं होता है. It is the elastotic degeneration of the your conjunctival stroma, right? It is the elastotic degenerator of the conjunctival stroma, and this is most commonly seen in the nasally, right? And what are the most common cause? It is the UV exposure is the most common cause. This UVB rays are the main cause of it. Okay, so UVB rays are the UV rays or B rays are the most common cause of it, and it is having what? It is having the head cap and then cellular infiltration and is having the body of it. The glass rod test is there that does not pass through the pterygium. And what are the treatment of the choice, guys? As you know very well, no medical management for the pterygium. We should have to use the your autografting, right? Autograft should be done. We have to excise it. Yeah, excision should be done. But if we do the normal excision, it have the more over chances of the if we done the just do the simple excision, it is having the more over 90% of chances of the patient is having to reoccur. So what we have to do nowadays, we are doing in the best treatment. We do the excision. After the excision, we put over their autograft, right? So as we put over the autograft, so there are the very less chances to do the get the pterygium recurrency. Understand? The next we are starting with the dry eye, which is also known as the keratoconjunctivitis sicca, right? The tear film, as you know, the tear film having the three layers: the mucin layer, from the globate layer, aqueous layer, from the lacrimal gland, and the uppermost layer is the lipid layer. So it is from the inner to outer. Okay, outer is the lipid, the second aqueous, the third inner one the mucin layer. Right? Which one is the thickest? Yes, the aqueous one is the thickest. What are the diagnostic tests for the dry eye or the keratoconjunctivitis sicca? We are doing the Schimmer's test, which you know very well. As you know, we'll put the simmer stick and we have to see should be the less than 5 mm. But if it is the more than 10 seconds and it has remained the dry eye, right? And next we have the your phenol red thread, which is having the less than 9 mm, which is having the severe dry eye, right? Now, if we talk about the treatment of it, right? If we talking about the now the treatment of the pterygium, as we talk about it, only Braille sclera, which is have the simple excision. If we do, there is a high risk, 30 to 50%. It can be reoccurrence. If with the excision we give the mitomycin C, it is have the interruptive application. There is a medium risk of the scleral necrosis. And the autografting is the conjunctival autograft. This is the lowest occurrence. Just 5 to 10% are the again reoccurrence is there. So remember about the FMG key points again. FMG key point is saying the autograft is the treatment of the choice of the pterygium for the lowest reoccurrence. Yes, the Simmers is the less than 5 but more than 10-second dry eye. And please remember the pterygium is most commonly nasally caused by the UVB rays, right? UVB rays. So this is about the your conjunctiva, conjunctivitis, and your about the your pterygium and the dry eye, fictinocular conjunctivitis and pterygium and the dry eye. The next, we are now moving for the sixth topic of the today and the lacrimal system. Before starting the lacrimal system, we are taking a short break, right? Just a short break for the 2 minutes, 2 to 3 minutes, like just 2 minutes break. Okay, then we're going to start about the your lacrimal system. Okay, just 2 minute break. Am I clearly audible and visible, guys? This was just a short break. Let me know in the chat box, guys. Am I clearly audible and visible? So we'll start the class. Waiting for your comments. Okay, okay, perfect. Right, audio, video, perfect. Chalo, very good. ठीक है, audio, video, perfect. Chalo. Now we are moving forward for the next topic, which is your lacrimal system and the dry eye. Related to the lacrimal system, yes, for the tear film, right? It is related to their tear film. The first of all, we have to talk about the lacrimal drainage system. Yes, the lacrimal drainage system. Also, the infection of it, which is known as dacrocystitis. Okay, so we'll talk about the dacrocystitis. The first of all, we have to talk about the lacrimal drainage system and the pathway. So the pathway of the lacrimal system, you know, the first of all, the lacrimal gland, which is available in the superior temporal part. So just I'm writing here this short form, superior temporal part, and then this will be giving this lacrimal gland will give the secretion comes to the passing through the whole eye, supplying the lacrimal your tear film lacrimal layer, comes to the punctum. After the punctum, it's come to the your caniculi, then upper caniculi, lower caniculi, two caniculi are there. Then it is come to the common caniculus. They both upper and lower will be joined together and make the common caniculus. And then this common caniculus. Now this common caniculus, this yes, your common caniculus will be going to yes, your common canicular will be going to drain into the lacrimal sac. This lacrimal sac will give this all this drainage to the nasolacrimal duct. It will give into the nasolacrimal duct, and you know very well the nasolacrimal duct will be open into the inferior meatus of nose. I hope you studied this in the ENT also. This inferior meatus is draining the nasolacrimal duct, right? So all the three meatus are there: inferior meatus, then middle meatus, superior meatus, and superior meatus, right? So superior res is also there, right? So now the infection of this your lacrimal sac is known as your congenital dacrocystitis, right? The dacrocystitis is what? The inflammation of lacrimal sac. But here is the no, in the congenital dacrocystitis, what will be the highest starting? Please remember, this is due to the persistence of the membrane at the wall of Eisner. What is the wall of Eisner? When the nasolacrimal duct open into the inferior meatus, there is a valve. And what is this? This is the valve of Eisner. Okay, which wall? It is having the wall of Eisner. If this wall of Eisner is having the membrane, covered with the membrane, now what will be happen? If the membrane is covering this wall of Eisner, due to this, there is no drainage will be there. So now, if it is not getting drainage into the inferior meatus, this lacrimal secretions will be remain into the this lacrimal. Yes, your lacrimal secretion will be remain into the nasolacrimal duct and the lacrimal sac. So your lacrimal sac will be getting full. ठीक है, lacrimal sac क्या हो जाएगा? Full हो जाएगा. And why? Because this is the blockage at the nasolacrimal duct, blockage of the nasolacrimal duct at the inferior meatus. And the reason is what? Yes, what is the pathophysiology? This is the wall of Eisner is having the membrane over there. The wall of Eisner is having the membrane over there. Now, the treatment part, as we already know, right? Very controversial question is over there. Just remember about it. If the child is less than 9 months, okay, if the child is just less than 9 months, the your dacrocystitis massage, yes, your lacrimal sac massage and antibiotic is the treatment. Lacrimal sac massage and antibiotic is the treatment. 9 to 18 months should be the probing, right? The probing should be done over there. And if age the more than 4 years, the DCR, dacrocystorhinostomy should be the done, which is the your choice. Like we can say the surgery of the choice, like final है ना. अगर नहीं हो रहा है ट्रीटमेंट, हमने क्या कर लिया, lacrimal sac massage भी हो गया, and then probing भी कर लिया, then still not opening. Final is the DCR. And please remember the DCR is the your opening, because वहां पर तो wall of Eisner पे तो क्या है, membrane है, inferior meatus में. Now we make a bypass, and this bypass will be open at what? Yes, this bypass will be going to open at middle meatus. Okay, this DCR. Now after the DCR, your NLD, your nasolacrimal duct will be going to open at the, yes, open at the middle meatus. The probe direction should be the ala of nose, which is the down, lateral, and backward. Please remember always the downwards, laterally, and the backward is the your direction of the probe when we are doing the probing of the congenital dacrocystitis. The later on we have the two type of acute and chronic dacrocystitis. Please remember, in the acute there is a painful red swollen pus at the sac. यहाँ पर हमें अलग से pus दिखेगा. The most common organism is Staph aureus, and what is the main the issue is there? It can be the sequentially, it can cause the your lacrimal fistula. It can be make the opening over out of there. It can make the fistula over there. What will be done in the chronic? In the chronic dacrocystitis, it is more commonly seen in the females, and the treatment should be your DCR. Yes, DCR, dacrocystorhinostomy. Is it clear? Now, if the fibrosis also, then also we do the DCR. Is it clear? Clear? Chalo. Now, what are the tests as we talk about it for the checking this lacrimal system? We have to do the test. The first is the syringing. We take the senile. We can take the saline and irrigation through the punctum. We start the irrigating through the punctum. This is the mainly hardest stop, this which is the lower passage, and the soft to the upper block. And the syringing can be helpful in this patient, right? If the syringing we can do in this cases. The next we have the dacroscintigraphy. What is this? There is a radioactive trace in the tear film we should be give, and best for the pump failure detection. We are doing this for the bestly for the pump failure detection. Also, we can do the Jones dye test. We can fluorescent eye should be given in the eye, and the cotton in the nose. We can put the cotton in the nose. So this can be come to the, if the Jones dyes came to the nose, like it means the NLD and this function is working. If not, then it will be the your obstruction. So this can be the primary and secondary locating of the obstructions at the which level we have the obstructions, right? So remember about the FMG key points again. What is FMG key point is saying? Dacroscintigraphy is the best test for the lacrimal pump failure, right? And please remember the first sign of your first sign of your CST. The CST is what? Yes, congenital dacrocystitis. In this, there will be the sixth nerve palsy. Probing best for the probing is the best for the your 18-month for the congenital dacrocystitis. So we can do this all this test for the your lacrimal system, right? Moving forward. Next topic is the uveitis, and moving forward for the uveitis, we are starting with the uveitis, which is the anterior uveitis. So as we talk about the uveitis, you know very well, eye ophthalmology, eye anatomy, right? In ophthalmological anatomy, you know very well, we have the three layers. What we have the three layers. What are the three layers we are having? We are having the outer fibrous layer, we have the middle uveal layer, and we have the inner nervous layer. So this middle uveal layer, which is having the ciliary body, iris, please remember iris, ciliary body, and the posteriorly we have the choroid. This all are three is known as the uvea, right? This all are known as the uvea or uveal system. Now, if this uveal system is getting the inflammation, itis is inflammation, that is known as your uveitis. Now, we are starting with the types of it. You can see over there. The first one, which is the anterior uveitis, the location is the iris and the ciliary body. Yes, iris and the ciliary body involvement. The next, we have the intermediate. In this, the pars plana and the vitreous, the posteriorly, right? The ciliary body have the two parts, pars pliccata and pars plana. So the pars pliccata will be in the anterior one, and pars plana will be in the intermediate one. The next we have the posterior one, which is having the choroid and the retina involvement. And please remember the last one, which is the pen uveitis. All the layers from the starting from the iris, ciliary body, pars plana, pars pliccata, vitreous, choroid, retina, all of these are getting involvement in this. The anterior uveitis having the key feature of KP bodies, aqueous cell, flare, and the synechiae will be going to seen in there. What are the KP bodies? These are the mutton fed bodies will be seen over the endothelium of the cornea. the aqueous cells will be going to seen, the aqueous bubbles will be going to seen into the anterior chamber. The flare, the patient is having this due to this cells, this the patient is having the flare and the synecdoche can be present in this. Also the intermediated one, because it is related to the vitreous behind it, so there will be the snow banking, snowballs, and the vitritis key features will be going to seen over there. In the posterior one, the patient is having the choroiditis or retinitis or the vasculitis. The vessels of the retina can be getting involvement in this. The vasculitis will be seen over there. In the panuveitis, please remember there is a diffuse inflammatory uh, signs will be going to seen in this condition, right? Next, now the types of the anterior uveitis are divided into the non-granulomatous anterior uveitis and the granulomatous anterior uveitis. So anterior uveitis is divided into the further two types. Okay, most commonly in the FMG exam they are asking from the anterior uveitis. Always they are asking question from the anterior uveitis. Please remember about it. Intermediate and posterior are very less, right? In the previous year they didn't ask yet, right? The non-granulomatous we are starting with it. These are the fine keratin participates will be there, and they are small, white, and diffuse. The keratin participates are also present, KPs are present, but they are very fine, okay, and small and whitely diffused, right? Also, the Kopay nodules at the pupillary margin. At the pupillary margin, there will be the Kopay nodules will be seen. And please remember, this is most commonly associated with the your HLA-B27, right? This is most commonly associated with the HLA-B27. The patient is having the acute onset, painful, and photophobia will be by this and the non-granulomatous anterior uveitis. But if we're talking about the granulomatous anterior uveitis, there will be the mutton fat capes, right? Mutton fat, they have the large and greasy. Please remember the large greasy capes bodies are seen in this condition. Also, if we're talking about it, with the large capes, there is the your Buccal nodules will be seen in the iris surface. Please remember the Kopay nodules will be seen in the non-granulomatous, right? And there is a Buccal nodules will be seen on the granulomatous. Please remember about it. Also, the Earth's triangle, which is the max area of the capes, will be seen. The Earth's triangle will be going to seen. The causative organism for the granulomatous, please remember the TB, syphilis, and the sarcoidosis. All right, and the insidious onset will be the less painful. Please remember for it. They are the insidious onset, and the granulomatous will be having the less painful. Now, the key point for you is the KP is the low cornea due to the conventional current, and aqueous cell are the sign for the active inflammation. The inflammation is going on. Yes, active sign, aqueous cells. Copper's nodule are in the non-granulomatous, and Buccal nodule will be seen in the cases of your uh, granulomatous. Okay, Copper's nodule and the non-granulomatous, and Buccal nodule will be seen in the granulomatous. Is it clear? So this is about the anterior, but now we have to talk about the intermediated and posterior uveitis also, right? The intermediated uveitis is known as the pars planitis also, right? Because the pars plana and the vitreous part is involving over there. So the inflammation of the vitreous pars plana, and the peripheral retina will be going to seen in this condition, right? So only the pars plana, ठीक है, pars पीछे वाला part ciliary body का pars placata and plana. So the pars plana, the posterior part of it, and also please remember, and also there will be the involvement of what? Yes, involvement of the your peripheral retina and the vitreous also, right? Vitreous is getting also, because at the vitreous parts plana वाला part जो है that is getting attachment, वो touch में रहता है vitreous के, so the vitreous attachment will be there. Now, moving forward for the next, there will be the snow banking seen in the periphery, and the snowballs will be the inflammatory exudate in the vitreous. The patient is having the snowball appearance, like patient is saying the snowball जैसा कुछ दिख रहा है. So what is this? This is the inflammatory exudates which is floating in the vitreous. Vitreous should be the transparent. Understand, for the vision. And the what are the cause of it? Please remember the 70 to 75% is the idiopathic. Okay, it is the idiopathic. Also, the treatment is for this is the steroid and immunosuppressive therapy should be given in this cases, right? Also, the posterior uveitis, please remember the posterior uveitis are the causes by the toxoplasmosis, which is the most common cause. The patient is having the fog, headlight and fog appearance. Also, the patient is having the CMF retinitis, which is the most commonly seen in the HIV, which is seen in the pizza pie. Yes, which is seen in the pizza pie appearance is having there. Also, it is having the sympathetic ophthalmitis, which is having the Dallin-Fitch nodules, which have the Dallin-Fitch nodules. Also, the perforated injury, uveitis, can be seen in the other eye also, in the perforated uveitis. And please remember about it, never before the 2 week, the retinal S antigens should be seen in this case. The CMS retinitis, the CMV, cytomegalovirus retinitis, which is the most common opportunistic infection in the HIV. So we have to remember about your CMV, cytomegalovirus retinitis in the HIV, right? It is most opportunistic infection. Now there is the Margherita pizza. Please remember the Margherita pizza, because the sauces and cheesy retinopathy. The retinopathy seems like fatty exudates, which is a cheesy, and red briefly because of the your blood vessels, right? Vessel leakage. So this will be, we can say, the Margherita pizza sign, and also we can say the sauces and cheesy retinopathy, right? Because of the hemorrhage and the necrosis. And in this case, please remember there will be HIV micro angiopathy will be going to seen, and due to this there will be the cotton wool appearance will be going to seen, right? Cotton wool appearance. What should be the treatment? Please remember, add the gencyclovir and valacyclovir IV induction, and the oral maintenance dose should be given in this cases of the patient with the CMF retinitis. Also, there is the immune recovery uveitis, which is the, we can give the heart therapy, which is the paradoxical worsening cases, we can give the heart, right? Now the next, if we're talking about the FMG key points, please remember about it. The your cytomegalovirus retinitis is the most opportunistic infection in HIV, pizza pie appearance, and please remember the toxoplasmosis is the most common posterior uveitis. Okay, so most opportunistic in the HIV, we should go with the CMF, your cytomegalovirus. And if we talk about the most common posterior uveitis, that should be the your toxoplasmosis. In the symptomatic ophthalmitis, there is a Dallin-Fitch nodules. Dallin-Fitch nodules will be finding over there, right? So this is all about your uveitis, which you have to remember in this. Now, moving forward for the next, which is your neuro-ophthalmology, right? Starting with the neuro-ophthalmology, with the first one, we are starting with the optic nerve and your RAPD, right? What is the mean of optic nerve anatomy? First of all, please remember the length of it is just 3.5 to 5 centimeters, the total length of the optic nerve. The longest part is the intraorbital. Okay, the longest part is the intraorbital, is the 30 to 25 to 30 mm. Rest the parts of it is the intraocular, intraorbital, intraarticular, intracranicular, and then intracranial, right? Intracranicular and intracranial. Now, the first sign of the optic nerve disease is your RAPD. We have to talk about this particular, which is your relevant afferent pathway defect, right? And we have to talk about this for the optic nerve diseases causing the red-green color defect also, right? Optic nerve disease. The exception, the glaucoma can cause the blue-yellow defect also, because in the glaucoma also we have the optic neuropathy, right? Let's talk about this Marcus Gunn people, which is have the relatively afferent pathway defect. In this condition, what will be, this is diagnosed by the swinging flashlight test. What we are doing, we are doing with the swinging flashlight test. When the torch move to the affected eye, what will be happen as I move the torch, the swinging flashlight test I am doing, as the torch will be moved to the affected eye. Means if I am giving a case, the patient is having the right side affected eye, so this pupil will be getting dilates instead of the constricting, right? So right affected eye, if I put the torchlight on the left eye, the both eye will do the constriction. As I give to the light into the affected eye, it will show the dilations, because this affected eye is having the afferent pathway defect, right? The defect is in the afferent pathway, so it is not going into the senses, because as we know, in the pupillary pathway we have the afferent and efferent pathway. So afferent pathway is having the different, but efferent pathway is the common. So that's why when we are putting the light into the left eye, the both eyes doing the constriction, right? And indication is your relative afferent defect. Of course, swinging fatalities में हमें क्या मिलेगा? We understand that the patient is having on the right side relative, the patient is having the afferent defect, and this is seen in the optic neuritis, or in the cases of your central retinal venous occlusion, or in the severe retinal diseases, right? In the severe retinal diseases, we are going to find this. This is not seen in the media opacities, or any refractive error will be going to not seen in these cases. But what kind of the visual field defect can be find in this optic neuritis? We can see if the patient is having the central scotoma, so the optic nerve diseases is there, and the disease is your optic neuritis, or the toxic amblyopia can be there. But the patient is having the centrocecal scotoma. In this condition, there is the tobacco, we can say the tobacco amblyopia, which is cyanide destroying the optic nerve. Burgess scotoma, we already talked about it, the glaucoma, it can seen in the nerve fiber damage in the bundle defect, and we have the attenuated defect, which is the your, we can see in the your anterior ischemic optic nerve optic neuritis, right? Anterior ischemic optic nerve neuritis. Maybe it can be atteractic or maybe non-atteractic, right? दो तरीके का होता है. Please remember about it, right? In the FMG, they are not asking about the attractic and non-attractic, but please remember, it can be attenuated defect can be seen in the your anterior ischemic optic neuritis. Can be the attractic type and not attractic type. Please remember about it. So superior and inferior half of the loss will be seen in the in such ischemic conditions. The key feature are saying the relative afferent pupillary defect is the first sign of optic nerve disease, and the swinging petalized test for the which is the test we have to do. Optic nerve disease have the red green color defect, except the glaucoma. Glaucoma is having the blue yellow color defect. Okay, please remember about it. Now, moving forward for the next, which is your topic important, which is your papilledema and your anterior ischemic optic neuropathy, right? Now, papilledema, if we're talking about the papilledema, this is the bilateral disc edema due to the increasing in the intracranial pressure. Now, this is not the IOP, guys. Please remember, this is the ICP. The ICP is your intracranial pressure. Okay, so the pressure is increasing in the cranial cavity. Okay, intracranial pressure is getting increasing. Now, the first sign will be there is the venous dilatations, and the visual field effect will be the enlarging of the blind spot. This is the feature which we have to markedly seen. The patient is having what? Patient is having the enlargement of the blind spot is going to seen in these cases. Now, what are the causes here? Please remember the imbalance of the pressure inside the brain, which is increasing the intracranial pressure. Also, it can be the stasis of the your exoplasmic flow, right? Can be stresses of the exoplasmic flow can be seen over there. No visual loss until late, like in the optic neuritis cases. And the later on, it will be going to see. But in the your anterior ischemic optic neuropathy. Now, listen this part. It have attractic, which is we can say the giant cell arteritis. We say this the giant cell arteritis is the known as attractic anterior ischemic optic neuropathy, and then we have the non-attractic, right? Non-attractic anterior ischemic optic neuritis. In what are the different with the giant cell arteritis? There is a sudden painful loss of the vision, and this the patient is having the attenuated field defect, and the patient is having the relative afferent pathway defect, and the ESR and the CRP will be the elevated seen in this giant cell arteritis. But if we're talking about the if we're talking about the non-attractic, if we're talking about the non-attractic in ischemic optic neuropathy, in this there is a sudden painless, right? Painless loss of vision, which is the morning complaint. जब भी patient उठा, patient बोल रहा है there is a painless loss of vision, right? Sudden loss of painless vision, and this is the nocturnal hypertension and can be seen in the crowded disc. Now, what is the giant cell arteritis? As we talk, we say it to the anterior ischemic attractic anterior ischemic optic neuropathy. So the emergency management, what should be done? We have to give the IV methylprednisolone 1 gram per day for the 3 days. Start immediately if suspected, right? Also, the temporal artery biopsy within the 2 weeks of the starting the steroid. Also, we can do the anosmias fugax. In this, the transient curtain-like vision loss will be seen in this condition. Also, we can do the pseudo kidney in the anion case, in the non-attenuated, which is the true foxit kidney, which is the olfactory groove tumor, right? It can be the seen in the olfactory groove tumor. Now, what are the key features are saying? Please remember the first sign of the papilledema is the venous dilatation. Okay, it is a your venous dilatation. What is your giant cell arteritis treatment? IV methylprednisolone immediately we should be given. And now the case, please remember, in the arteriated anterior ischemic optic neuropathy, it is a painful loss of vision. And in the non-arteriated, please remember, that is your painless. So arteriated painful hoga, non-arteriated painless hoga. This is the difference. Now, also the pupil abnormalities and the Horner syndrome, which we have to talk about it. In the pupillar abnormalities, we have the Argyll-Robertson pupil and the homeless Addis pupil. We have Addis-Tonic pupil also, and we have the Horner syndrome. Let's talk about it one by one. We're starting with the first one, which is the Argyll-Robertson pupil. There is a small irregular pupil. The patient is coming to you. What is the patient is having? Very small and irregular pupil, and the patient is having the light near dissociation. Please remember about it. The patient is having the light near dissociation. It means there is a no constriction to the light. When we put the light, there is a no constriction, and there is a constrict to the near. It constricts to the near when we give the near object. There, it is most commonly seen. The Argyll-Robertson pupil is most commonly seen in the neurocephalus, right? Also, it can be seen in the can be seen in the multiple sclerosis, the diabetes mellitus, or the sarcoidosis. Also, it can be seen over there. But what about the Addis-Tonic pupil? There is a unilateral mid-dilated pupil. It means it is not the constricted, not the dilated. It is called the mid-dilated pupil, and it is called as the tonic pupil in the middle-aged females. It is seen in the middle-aged female. And what is the mean? Please remember what it reacts 0.125% of the pilocarpine, which is the your degenerative very less, right? We can say very less. And please remember also it is decrease in the deep tendon reflex in the patient. In the Argyll Roberts, in the Addis-Tonic pupil, the patient is having what? The sensitive. It is doing the, it reacts to the pilocarpine. It's do the mitosis, right? Pura constrict ho jayega pupil. When we give the very less of the 0.125% of the pilocarpine should be given. And also it is decrease in the deep tendon reflex also will be seen. Let's talk about the Horner syndrome. There should be the seen the ptosis and the meiosis and the sympathetic chain lesion. There is a sympathetic chain lesion. The Horner syndrome is the sympathetic chain lesion. Pancreas tumor is the main cause of it in this, and the anhydrosis if the first and the second order. So the three things should be present: the ptosis and meiosis. Also, there is anhydrosis should be present, right? So these three things should be present over there: ptosis, meiosis, and anhydrosis. Also, it have the anophthalmos, and it is, please remember, the patient is having the congenital heterochromic iriditis, right? The patient is having the congenital heterochromic iriditis. So the both of the iris having the different color, heterochromic iriditis, right? Congenitally. Now, let's talk about the anisoconia. In this, pupil size are different. If more prominent in light, this the dilatation eye is abnormal. If more prominent in dark, this the constricted eye is abnormal. Okay, so what is the anisoconia? The pupil size differences. If the both of the pupil are having the different size, so what we are doing, if more prominent in light, है ना, dilatation if more prominent रहती है light के अंदर, ठीक है, so the dilatation जो eye is dilated है वो वाला affected है, वो abnormal है. Or if we seen in the dark condition, which eye is constricted in the dark, that is the abnormal, because the normal condition light में क्या होना चाहिए? Constriction, dark में होना चाहिए dilatation. ठीक है, सो अगर लाइट के अंदर भी क्या है, वो लाइट के अंदर डायलेटेड है तो वो अफेक्टेड है, और डार्क के अंदर कॉन्स्ट्रिक्टेड है तो ऑफकोर्स वो अफेक्टेड है, आई अफेक्टेड है. Pharmacological mydriasis, if I'm talking about it, there is a no constriction, even 1% pilocarpine. It is the your homeless Addis, which is the react, which homeless Addis, which is the reacts with the 0.125, right? Also, the Hickston's pupil, please remember, it is initial meiosis and then mydriasis for the comparative, the third nerve lesion, which is the your unchal heritations. We are seeing in the third nerve compressor, right? Compressive with the third nerve lesions, right? And the key point is saying here, Argyll-Robertson people, the FMGE point is say Argyll-Robertson people, light near dissociation, which is seen in the neurosyphilis, and your homicide is react to the 0.125 pilocarpine, and the Horner syndrome most common cause is the Pancreas tumor, plus the patient is having the heterochromia iritis from the congenitally. Please remember, heterochromic iritis is the congenitally cause in the patient of the your Horner syndrome, in the case of patient of the Horner syndrome, right? Very good. let's move forward. Let's move forward for the next diseases. And now we have the visual pathway lesions. Now, very important topic, very important slide. I'm making a star over here so that you can remember about it. Okay, this is a very important slide. 1 mark can be come from this particularly. Okay, now remember about it. There is a lesions are seen over here, like at the optic nerve, optic chiasma, optic tract, temporal lobe, parietal lobe, visual cortex, and the your lateral geniculate body. Lateral geniculate body. So now, if we're talking about this, now what kind of the lesion? First, the second we have the visual defect. कैसा defect दिखेगा? And what are the causes are there? The common causes we have to talk about it. So the lesion, if we talk about the total optic nerve is getting lesion. Okay, पूरा एक side का top optic nerve ही चला गया. So the total blindness will be seen in that particular eye. If I'm talking about like left eye, the patient is having the left eye optic nerve is lesion. Okay, पूरा left eye का optic nerve ही चला गया. So the total left eye will be getting the blind. Okay, and the patient is the reason of it. It can be the optic neuritis or can be the trauma, right? So it can be the optic neuritis and the trauma of the optic nerve damage. If the optic chiasma, please remember, this is the central chiasma lesion. We are talking about the centrally, okay, na? Chiasma where the temporal fibers are getting crossed, we can say, right? Where the temporal fibers are getting crossed, right? So there will be seen the the nasal fiber is getting crossed. If I'm talking about it, the temporal vision, okay, nasal fiber cross करेंगे, sorry for that. Yes, so central chiasmal lesion where the nasal fiber is getting crossed, the temporal will be uncrossed जाता है ना, temporal uncrossed continue करेगा, the crossing of the nasal fibers will be there, so the visual defect will be seen the bitemporal hemianopia. This is the frequently asked question in the FMGE NEET PG exam, right? And the common cause is the pituitary tumor. So they can mention you in the exam in a clinical case scenario, the patient is having the pituitary adenoma, and then what kind of the visual field defect you are going to find in this particular patient. So this is related to the about, yes, this is related about to your visual pathway lesions. The next we have the optic tract. Please remember the optic tract lesion is having the incutaneous homonymous hemianopia on the same side of the homonymous hemianopia. It is seen in the craniopharyngioma, right? Craniopharyngioma can be seen. Now the temporal lobe is having the Mayer's loop, okay, which is the inferior fibers. In the inferior fibers, the superior quadrant is gone, and that is known as the your pie in sky. This is known as pie in the sky, and this is commonly seen in the temporal lobe tumors. It can be seen in the temporal lobe tumors. The parietal lobe, which is the superior fiber, parietal lobe में superior fiber होगा. Now there will be the inferior quadrant will be gone, which is known as pie on the floor. Pie on the floor. So pie in the sky, in the temporal lobe. देखो inferior fiber है तो inferior में superior quadrant जाएगा. Superior fiber है तो inferior quadrant जाएगा. Just remember about it. Superior में inferior, inferior में superior. So if the inferior fiber is gone, temporal lobe में, right, in Mayer's lobe, which is the inferior fiber, so pie will be in the sky. Okay. Now if we're talking about the parietal lobe, which is the superior fibers, it will be the inferior quadrant. Now the causes are the parietal lobe tumors. Causes are the parietal lobe tumors. What are the visual cortex? Please remember this is the occipital. It will be seen in the occipital lobe lesion, and this is the conversely homonymous hemianopia with macular sparing will be seen because of the visual cortex, and this will be seen in the posterior communicating artery or posterior cerebral artery. Stroke can be seen. The posterior cerebral artery stroke can be seen in this condition, right? The lateral geniculate body is having the homonymous hemianopia, which is having the wide shaped, and this can be seen in the vascular occlusion. The vessel occlusion causes will be seen. Remember, the lateral geniculate body is the 6 layer. 1, 4, 6 are the contralateral, and 2, 4, 2, 3, 5 is the ipsilateral, right? The parocellular is the color vision, and meganocellular gross movement, and conicocellular is the blue color. The defect occurrence will be seen in the your deep parietal lobe lesion, right? Is that clear? Now, what are the FMG key point are saying? Please remember the pituitary tumor, if they mention, please remember bitemporal hemianopia, temporal lobe, pie in sky, in parietal lobe, pie on floor, and the visual cortex is having the macular sparing. So, out of this FMG key point, I'm damn sure in your FMG exam, you will be going to find out one question from this particular slide. It is a very, very important slide for you guys. Okay. Now, not only this related into the neuro-ophthalmology, in the neuro-ophthalmology also, we having the nerve palsies, right? What we are having here, we are having the nerve palsies. In nerve palsies, what we are going to see over there, you guys can see over there in the eye, we have the three nerves importantly, the third nerve, cranial nerve number third, cranial nerve number four, and cranial nerve number six. So the palsies of these are having some features, and what are the medical causes, and what can be the compressive cases causes can be seen in this condition. So just look into it. In the third nerve palsy, we can see the ptosis, which is the severe ptosis. Guys, please remember the severe ptosis. Now compared to it, in the Horner syndrome, we have the mild ptosis because of the sympathetic chain defect. In this third nerve palsy, we can see the severe ptosis and the defect with the your which in the addition, superior or infiltration, and the pupil will be getting dilated. Okay, the pupil will be getting dilated because the third nerve supply the rest of the muscle like superior uh, rectus, inferior oblique, and medial rectus. So this all will be going to gone. So what will be going to seen? The eye will be, yes, the eye will be going to look downward and outward. Okay, downward and outward. Okay, yes, inferior, adducted, yes, outward, adducted, and inferior. Right now, the what can be the medial? Yes, medical cases. The pupillary sparing will be the diabetes mellitus, hypertension, which is the vasa varosum, or the pupillary involvement can be the your posterior cerebral artery aneurysm, as we already told about the pale vessels, right? Also, the cranial nerve number 4, palsy, we can see the heterotropia, worsen on the opposite gaze, and the same as the tilt. The same side the patient is having the tilting. Medical causes can be the diabetes, hypertension, and the trauma, and the compressive causes can be the your trigeminal ages or the trochlear granuloma. Right. The last with the sixth one, we have the esotropia. The patient is having the defective abduction, and the uncrossed diplopia. The patient is having the same causes, the diabetes, hypertension, and the increasing in the intracranial pressure. Also, there is the your pertus apex and the cavernous sinus can be the your compressive causes of there. Now, important, which is the brainstem syndromes can be here, the Weber's, Beckett's, and the Millard Gruber. What will be the features in this? Please remember third nerve palsy and the contralateral hemiplegia, right at the site of midbrain. It is involving Weber. The pancreatic will be the third nerve contralateral tumor and ataxia. It can be midbrain tegmentum will be affected. And in the Millard Gulber will be seeing the fourth, seventh contralateral or sixth, seventh contralateral hemiplegia. The pons are the involvement in this condition. What are the FMG key point is saying? The third nerve palsy, the pupillary sparing, and the medical condition will be hypertension, diabetes, pupillary involvement will be the compressive, will be seen in the your posterior cerebral artery aneurysm, and the sixth nerve palsy will be the first sign of your CTS. Please remember about it. These are the important nerve palsies related to your neuro-ophthalmology. Now, talking about the next, which is the your orbit and oculoplasty. Let's talk about the orbit anatomy. And in the orbit anatomy, as we already talked about it, the capacity is the 30 cc, and it is the quadrilateral pyramidal shape. Let's talk about the now the important. The weakest wall is the medial wall. Okay, the weakest is the floor for the postomedially. Okay, weakest floor, right? Weakest wall is the medial wall, and weakest is the floor also, right? Weakest floor is the postomedially. The nerve outside the anus is the your LFT. It means the lacrimal, then frontal, then trochlear. Okay. Next, optic nerve, optic artery in the optic foramen. So, in the nerve outside the annulus will be the LFT, lacrimal nerve, frontal, and the trochlear. But in the optic foramen, we have the optic nerve and optic ophthalmic artery will be there. Now, the disease related to this, we have the proptosis. What is the mean of proptosis? In the cases of thyroid eye disease, there is a more than 21 mm front lateral orbital margin or to the corneal apex will be seen, and the difference will be the more than 2 mm between the both of the eyes, right? The normal or abnormal may more than 2 mm. There is a head atrial exophthalmometer for the diagnosis. So we have the aerial, though that can be give us the our proptosis. The eye is bulging out or coming out, right? So the axial, the cavernous hemangioma, or non-axial, there can be the lacrimal gland tumor can be seen. What are the features? Please remember, the first muscle involved is the inferior rectus in thyroid eye disease. The first defective movement is the elevation, as the your inferior rectus is getting restricted. What will be the first sign? There is a dilymphant sign. What is the dilymphant sign? Lid lag retraction. The upper lid will be remain lagged. Okay, and the staring look, it is known as Kocher signs. The name is the Kocher sign. It will be the infrequent blinking and the staring look. Okay, infrequent blinking and the staring look. What is the weakest orbital wall? Which is the medial. Please remember. And the first muscle is involved in the thyroid eye disease is your inferior rectus. First sign, remember Darlimphant sign, okay, which is known as lid retraction. So these are the three important FMGE key points which you have to remember in this orbit and thyroid eye disease cases. Clear? Moving forward for the next. Now, moving forward for the next is the your topic, which is the orbital cellulitis and tumors and the trauma related to the orbit. Now listen this part, very important. The first of all, completing the orbital cellulitis. What is the mean of orbital cellulitis? This is the ocular emergency. In this, there is the inflammation behind the orbital septum. So orbital septum ke piche we have the subcutaneous fatty tissues that will be getting the this subcutaneous we can say the subcutaneous fatty tissues are there, which is getting the inflammation over there, and there are the risk of the your cavernous sinus thrombosis. This is a very high risk of cavernous sinus. This is the first sign of the cavernous sinus thrombosis is the your sixth nerve palsy. Your sixth nerve palsy. The causes are the Streptococcus, Strep aureus, or the H influenza, and the mucormycosis in the immunocompromised patient. So the treatment of this immunocompromised mucormycosis, we have to give the IV amphotericin B. In the rest conditions, we have to give the for fight antibiotics should be given in this orbital cellulitis. The orbital tumors, which we have to talk about it, like the lacrimal gland tumor, which is the non-axial proptosis and dystrophy down, and it is the most commonly begin with the pleomorphic adenoma, and the most common malignant and benign pleomorphic adenoma, most commonly malignant, is the adenoid cystic carcinoma. The cavernous hemangioma is the most adult axial type of the orbital tumor, and capillary hemangioma is the most commonly seen in the child. Adult में हमने देखने के लिए मिलेगा cavernous hemangioma. The capillary hemangioma is the most commonly seen in the child. Understood? Now, the important topic, please mark the highlight over here, and this is about your blowout fracture. Okay, so first of all, just talk about the blowout fracture. In the blowout fracture, the orbital floor will be getting fracture, right? Any orbital fracture will be called as the blowout fracture, right? And the commonly it will be the by the floor fracture, commonly seen the floor fracture. The teardrop sign will be seen on the CT scan. Will on the CT scan we're going to find the teardrop sign, and what will be the your inferior rectus entrapped. There will be the anophthalmos, and the diplopia will be seen on the up gauge. When the patient is doing the up gauge, there will be the diplopia, and the inferior in the blowout fracture, if the floor is involvement, there is an inferior orbital nerve will be getting damaged. So below the orbit, there is a no sensations will be felt by the patient. The torsal hurt syndrome will be there. There is the granulomatous inflammation of the cavernous sinus plus your supraorbital fissure, painful ophthalmoplegia will be going to seen in this condition, and the steroid responsive. This syndrome is the steroid responsive. The orbital apex syndrome, where this is the optic nerve plus three third nerve, fourth nerve, sixth nerve, and fifth one nerve. The total ophthalmoplegia plus vision loss. There is the total ophthalmoplegia plus vision loss will call as the orbital apex syndrome. Just remember about it. The orbital cellulitis is the ocular emergency because it is a risk of the what? This is the risk of the cavernous sinus thrombosis. The first sign of cavernous sinus thrombosis is the sixth nerve palsy. Capillary hemangioma, most commonly in child orbital tumor. Okay, most common child orbital tumor. Yes, most commonly child orbital we are talking about, not the intraocular. Please remember about it. Okay, chalo. Now we are moving forward for the next lid and adnexa topic. In the lid and adnexa, we have the topic for related to the ptosis and your blepharospasm syndromes. Right. Let's talk about the important topic, which is the ptosis. Okay, ptosis, it means the drooping of eyelid. What is the mean of the ptosis, guys? Here, yes, ptosis means the drooping of eyelid. Okay, so if the involuntary, okay, voluntary तो नहीं है, involuntary हुआ, involuntary drooping of the involuntary drooping of the eyelids. Now, talking about this ptosis, we have to talk about importantly. We have to talk about that importantly. The first one, we have to talk about the types of the ptosis, right? We have to talk about the types of the ptosis. In the type of the ptosis, we have the aponeurotic, right? Then we have the neurological, we have myogenic, we have the mechanical, and we have the congenital. So all the 5 type of the ptosis are mentioned over here. Now we have to talk about this, all the 5 of type of. The first one is the aponeurotic. In this condition, what the high lid cases most common type. It is age related. What is the cause? It is age related, and the treatment is the levator resection should be done, right? Your levator pulpibris superioris resection should be done in this case. The second one, we have the neurogenic, which is the third nerve palsy or the Horner syndrome are the features. If the cranial nerve number third, the lesion at the cranial nerve number third lesion or the sympathetic chain lesion can cause, and please remember we have to treat the underlying cause, right? If the third nerve lesion, we have to treat it. If the sympathetic chain lesion, we have to treat that. Myogenic cause like the myasthenia gravis or the fatigue. So this is the neuromuscular junction disease. So we can give the neoastigmatin or we can do the thymectomy, right? We can do the thymectomy, right? So this can be in the myogenic. Also in the mechanical, like mass edema or the scarring is there, like the physical weight on the lid will be there. So we have to remove the mass or we have to do the debulking of surgery of this particular mass which is covering over there. The congenital, there is a no lid decision, there's the lid lag, we can say, right? And this is the dysgenesis of the levator. So we can do the levator cassation or the frontalis slings, right? We can do the frontalis slings should be given in this condition. You have to remember about it. Very, very important, right? Related to the ptosis. Like blepharomosis syndrome, they can ask you also. Let's talk about the now blepharomosis ophthalmosis syndrome. What is this? This is the shortening of the horizontal lids, right? There is a shortening of the horizontal lids, and this is the applicus inversus. Due to this, there is the ptosis will be going to increase the intracathelic distance, right? The ptosis will be increased, and the congenital atrophion of the lower lid. So this will be caused as your blepharomosis syndrome, right? Other lid conditions like your lag of ophthalmos, the incomplete closing, right? In the gold implants, the sty, which is your streptococcus infection of the G's gland or the moles, we have to give the hot fermentation. Hydiolum internum, meibomian gland, very painful. Chalazion, which is your lipogranulomatous, we have to give the vertical incision in this case, and this is the painless condition in the lid, right? FMG key point is saying aponeurotic ptosis are the most common type of the eyelid seizure. We have to give the, and recurrent chalazion, the suspected of the sebaceous cell carcinoma. Please remember, and please remember blepharomosis is related to your FLOX2 gene. Please remember the gene which is involving there, this is known as your FLOX2, right? FLOX2 gene. Clear? Now, moving forward for the next, which is your Belfitis, Tracheasis, and the Anthropion, right? Belfitis, Tracheasis, and the Anthropion, right? The first of all, the type of that is the squamous. We have to talk about the ulcerative, posterior medullaris, and the seborrheic, right? Belfitis, we are talking. The squamous, there is a dandruff-like sclera will be on the lashes, and this is the seborrheic, causes the seborrheic dermatitis. We have to treat the lid hygiene, and the antibiotic or the steroid should be given in these cases. Next, we have the ulcerative. There is a matter cluster around the lashes, which can be bleeding out. Okay, that the cause is the your Staphylococcus aureus. The antibiotic ointment only should be given in these cases. The posterior and the meibomianitis the inflamed meibomian orifices will be there. This can be seen in the Cornea rosacea, and we have to give this the thermal pulsatization should be given in these cases. The last with the seborrheic. In the seborrheic, what is the gray scale association with the dandruff? And this is the related with the, again the seborrheic dermatitis. The lid hygiene and the baby shampoo should be used for it, right? Why the baby shampoo? Because that will be not getting irritation in the conjunctiva, right? So that's why we are giving the patient to use the baby shampoo for the washing of removing of this dandruff, right? Removing of this dandruff. Now let's talk about the tracheasis, entropion, and the dystrachiasis. What is the mean of tracheasis? This is the misdirected lashes towards the cornea, right? So this direction of the your eyelashes like this, they are coming outward and downward like this, okay? But if they misdirected and go inside or go towards the cornea, that is known as the tracheasis. Entropion, inward turning of the lid margin. The lid margin is turning inwards. Understood? Dystrachiasis, double row of the lashes, it should be present from the congenitally. And staphyloin is the adhesion of the bulbar and the palpebral conjunctiva. So they will be getting adhesion, right? That is known as staphyloin. The madarosis and poliosis and triosis. The madarosis is the loss of the lashes. There is the eyebrow is no there, right? There is a no eyebrow. Okay, so it will be seen, the madarosis will be seen in the laparosy. And poliosis, there is a grayish eyelashes. We can see in the vernal and VKH or the wet belonging. Also, tylosis will be the thickened lid margin. The lid margin is getting thickened and it will be seen in the chronic blepharophytis. And the clobomum of lid, it can be seen the notch defect in the upper lid with the teacher's cornless, right? The key point which we have to remember for the FMGE key point, please remember guys, it is the ulcerative blepharophytis are the Staph aureus and mebomonitis associated with the acnea rosacea, dystrachiasis, double row of lashes congenitally, no symptoms. Okay, there is a no symptoms by this double eyelashes. Okay, so no symptoms. ऐसा कुछ नहीं होगा कि patient is having the symptoms of it. So though there will be the no symptom will be present over there. Is it clear? Right. The rest of the topics like congenitally, the we can say talk about it. So let's talk about the rest of the topics. We have the last minute must know facts I given you in this particular slide that you have to remember. Please go with this last minute revision facts which you have to know about it. Please remember. Now, the key points are here. The total refractive power 58, right, to 60 diopter, 43 to 45 by the cornea, and the lens is having the 16 to 17 diopter. Normal IOP 10 to 21 mmHg, right? Aqueous humor rate 2 to 3 microliter per minute. Okay, 2 to 3 microliter per minute. Axial length 24 mm. Anterior chamber depth 2.4 to 2.5 mm. Clear? Next, lens derived from the surface ectoderm. Most common cause of blindness in India is the cataract. Most common preventable blindness is the glaucoma. Please remember, most common childhood blindness is the vitamin A deficiency, and phacolytic glaucoma is the most common complication of hypermature cataract, which is known as Morgangian cataract. Endophthalmitis is the most dangerous post-cataract complication by the staph epidermis. Just remember about it. It is just immediate after it. Just cataract surgery के बाद ही होगा. Clear? And Goldman tonometer is the most reliable. Understood? KF ring will be seen in the Wilson disease. Rubella triad is having the your cataract, heart defect plus deafness. And cytomegalovirus retinitis is having the most common opportunistic infection in the HIV patient. And please remember your central retinal artery occlusion is having the cherry red spot, and the window is the 90 minute window. Please remember the window period is the 90 minute. So memorizing this 15 facts very well, they appear repeatedly in the FMG exams. So that's why I conclude in this all into the last minute revision facts, right? Also, I will share this PDF with to you. So all the high comparisons, the important science of ophthalmology, all the related to the ophthalmological drugs in a one format, all this systemic drug, traumas, and the tumors related to it, I already posted over there. Okay, so you have to remember about it. Just one more topic I am going to covering here. The rest topic you can cover by yourself, no issues. Very easy topics are there. The retinoblastoma, which we have to talk about it very importantly. This is related to the RB1 gene tumor suppression, which is present on the 13 long arm Q14, right? And this is sporadically unilateral in the 60%, and the hereditary it is a bilateral by the 40%, right? It is the intraocular. We are talking about the intraocular tumor, right? The next we are talking about it. It is the hereditary earlier onset in the multifunctional. The most common presentation of this is the leukocoria. Okay, leukocoria. The leukocoria, it is a whitish pupillary reflex of the patient, right? In the child's eye. It is seen in the child age. Hai na? Most common spreading by the optic nerve, and most common non-ocular malignancy is the osteosarcoma. Please remember the Rosette Flexner Homer viscerate will be seen in the biopsy or the histopathology. You can say the histopathological. Okay, and there will be the bilateral retinal blastoma can be seen in the with this condition. RB gene you have to remember, hereditary, earlier onset, differentiate by the leukocoria. Please remember about the 6 P's of the leukocoria: persistent fetal vexation, retinoblastoma, Cohort's disease, toxosis, retinopathy of prematurity, and the cataract. The B scan for the retinoblastoma shows the calcification. T sign for the positive. Posterior T sign will be seen in the posterior scleritis. The choroidal melanoma is the most common adult intraocular malignancy, and the retinoblastoma is the most common child intraocular malignancy. Understood? So this all I concluded over there. You will be going to find this particular notes. You will be going to find this particular notes in the Telegram channel of Meduhub, right? The channel of Meduhub. Also, this will be going to find the Google Drive link below the description and in the chat box also present over there. And this notes will be available on my Telegram channel, which is the Ophthalmology by Dr. Vaibhav Ahuja. So best of luck for your FMGE examination from my side, and please revise this quick summary of ophthalmology which I given to you already. All the key points which I mentioned in every topic, that should be noted by you, and also that is a high yield topic I already covered over there, right? So this is your previous year topic. PYT based conclude revision which we had done with the high yield topics, right guys? Thank you so much for joining this session and making this interactive. uh, Best of luck for your exams. Thank you so much. Goodbye. Wishing you again best of luck for your examination.